One, please start. We are live.
Namaskar and good evening, everyone. I welcome you all on the second day of clinical updates in lung cancer, breast, ovarian cancer. And with immense pleasure, I would like to invite Dr. Jagdeep Singh, who is Assistant Professor, Medical Oncology, DMCH, AOI, Ludhiana, for the welcome and introductory note and to set the ball rolling. Over to you, sir, for the further proceedings.
Thank you so much. Actually, I welcome all my senior faculty. Basically, we have organized this, and it's my immense pleasure to invite you on this clinical updates in lung, breast, and ovarian cancer. And this is basically under the aegis of SOMICS Research and Enhanced Foundation, which is supported by the Cancer Research and Static Foundations. So I have on board Dr. Raman, who is a esteemed medical oncologist in my city. So very good evening to you, sir. And I can see on board Dr. Jatin is there, Dr. Navdeep, and Dr. Deepak is also there. They have already joined. So I think we can start the session right now. We are already getting late by some 5-10 minutes. So I invite Dr. Raman. He will be chairing the session for this abstract of the ESMO Lens 2022. So over to you, sir.
Okay. Thank you very much, Jagdeep. It's a nice experience to share our views and to learn from something from our colleague. The details of your program also. There are so many things which have come regarding molecular changes and DNA and immuno-oncology with chemotherapy, immunotherapy. Perhaps we are learning a lot. So it is not going to be just PDL1 or PD1. There is going to be TIL, there may be macrophages, and there can be something more to it. And I always say that, look, we are on an escalator of the knowledge. It is not going to be static. What you find that perhaps you are at the top after some time, and that depends upon the pace of development. Like in prostate cancer, there was nothing for some decades in HCC. And then suddenly there is a phase when it moves fast. And I look towards my colleague to enlighten for rest of the things, because they are going to present something. And I was going through some of the things about including this data of oral therapy. But when I went through the details, less than 50% of the patients didn't receive the treatment of hormone therapy at all with CDK4. So what is going to there? How we are going to interpret it? Right? And I leave it on to the presenter that how he handles it. Now it is over to the speakers, our esteemed speaker, and we learn everybody and then interact also. Thank you very much, Jagdeep, and all the best to the speaker.
So can I have Dr. Deepak Singla? He's there. So yes, Dr. Deepak, he's a renowned medical oncologist at Indus Mohali Hospital. So good evening, Dr. Deepak. So it's over to you.
Yeah, thank you so much. I think I'm audible right now. I'm in the OPD only, so I didn't go to my house. So
yes, you are.
Pooja, can you share the screen, please? Pooja, share the please.
Yes, sure.
So as Dr. Raman sir has told that we are on the escalator of the knowledge. So we are quite often see that we coming across in our day-to-day practice that many of our metastatic breast cancer patients who are hormone positive and HER2 negative, few of them, they do very well on the hormone therapy with or without CDK4 inhibitors. As we know that CDK4 inhibitors, it's in our nation that it is very, due to the financial constraint, and it's not everybody cup of tea. But few of them, they do simply on the hormone therapy like anastrozole, they do really well for years together, 1 year, 2 years. But few of them, they really, progress very fast. The progression-free survival is very less. So, I mean, that's what the importance of mutation signature analysis, which was presented in the ESMO 2022 in the Paris. So, why there is a reason is there is any genomic instability linked to the resistance to the endocrine therapy or CDK4/6 inhibition in the estrogen ER positive, hormone positive, and HER2 negative metastatic breast cancer. Next slide, please, Pooja. So basically, the breast cancer is having a complex genome, as we all are knowing, and mutations are happening throughout the life cycle of a cell, and when the multiple mutations are added together, mutation which is it is a is happening in the normal cell throughout the life, and it could be due to the occupational exposure, or it could be the mutation process due to the acquired DNA, acquired DNA repair, DNA repair defect like BRCA1, BRCA2, or it could be a mutational process occurring as a intermittent burst, and acquired DNA repair defect due to the it could be the occupational or maybe the excessive sunlight exposure, which is also promoting the mutagenesis. Next slide, please. Yes. So, what are the clinical significance of mutational signature in the cancer? As we know, from the HRD gene, homologous recombinant deficiency gene, we have a BRCA1, BRCA2, PALP2, and we have a PARP inhibitor plus platinum therapy in the patient with the HRD mutation. And in the MMR deficiency, we can prescribe the patient with the PDL1 immunotherapy. And now another thing is another lipoprotein family, which is linked to the resistance of the hormone therapy, is ApoBec family. It is basically a lipoprotein family which is responsible for the editing of a messenger RNA. Leading to the ApoBec activity. Unfortunately, till now, we are not having any specific target or any therapy in this state. But let's see in upcoming slide that how they are responsible that for the giving to the resistance to the hormone therapy. Next slide, please. So basically, ApoBec mutagenesis in breast cancer. So basically, as I told in the earlier slide, that it is responsible for our editing of the messenger RNA. Although basis is yet to be fully determined, it's a group of family of apolipoprotein, basically which is responsible 3A and 3B, and it facilitates the acquisition of mutation that can cause the progression. And basically, this ApoBec is responsible for the deamination of the protein. Next slide, please. So, what are the study question? This study was conducted in the Memorial Sloan Kettering, and which are the pathological and clinical feature of the breast cancer enriched in the for ApoBec or other mutational signatures? Do ApoBec has other mutational process have an impact on clinical benefit to standard treatments? Which are the genomic alteration that are enriched in the breast cancer with ApoBec mutation mutagenesis? Next slide, please. So for this study, next slide, please. So, what they have done is it was conducted by in the MSK team. So they have collected a clinical a cohort of 4495 breast cancer with clinical and pathological annotation, and afterwards cancer hotspots were determined, and gene and the pathway level functional alteration was determined, and detailed clinical annotation, and afterwards clinicogenomic analysis was done. Next slide, please. So what the challenge they have faced is during the mutational signature detection, that in the whole genome sequencing, there was a more than 4,500 substitution, but in the whole exome sequencing, it was only 43 substitution. while the target panel sequencing, there was only only one substitution was found. And coming to the mutation count, majority of the mutation was found in the SBS8 followed by SBS3, while in the mutation in the exome signature, it was only 35.4%, and in the unassigned it was 100% mutation count. Next slide, please. So method, they basically have done a target gene panel of 400 genes, somatic mutation and copy number alteration, and mutation signature from non-synonymous and silent somatic single nucleotide variants by sigma algorithm in sample with at least 5 single nucleotide variation. The fraction of mutation associated with a given mutation signature, and dominant one was top mutation signature per sample by sigma machine. Next slide, please. So after achieving that mutation panel, so what they have found is hormone positive metastatic breast cancer, especially the metastatic breast cancer, have a higher number of ApoBac as well as and the HRD signature, as it is depicted in this chart also. It is most commonly orange is the metastatic or post treatment. This blue is blue pillar is treatment naive. So in the majority of the metastatic patients, they have found is ApoBac mutation in the higher level. Next slide, please. So genomic evolution in the paired hormone
So you
positive.
are left with 1 minute to conclude your presentation.
Okay.
Thank you.
Okay. Can you forward the next slide, please? Next slide. Yes. So the most important is breast cancer with ApoBac are linked to the lobular phenotype with the highest mutation burden. They have found a highest mutation burden in the lobular carcinoma of the breast. Next slide, please. Next slide, please. As we can see, that PFS with the first endocrine monotherapy was very high, very low with ApoBac mutation. It was only 9 months. Next slide, please. While with the hormone therapy with the CDK4 inhibitors, it was with the HRD gene, which is responsible for the CDK4 inhibitor resistant. It was 7.6 months only. Next slide, please. So ApoBac dominant breast cancer have higher frequency of specific gene alteration linked to the endocrine resistant, out of which is the P10, KM2C, and ARDA1 and NF1 and PIK. Next slide, please. So gene enrichment analysis from sample of with dominant ApoBac, what they found is out of which CDH1 in the primary HER2 positive, it is CDH1 and Notch4, and in the TNBC, it is a ApoBac only, and in the metastatic cancers, it is a PIK3CA, which is the majority of the patient were having with the ApoBac mutation PIK3CA. Next slide, please. So PIK3CA mutation are enriched in the ApoBac dominant breast cancers as it is, and double PIK3CA mutant breast cancer, we can see is the signature in the green tower. We can see the highest number of the PIK mutant is the 51%. Next slide, please. So in summary, it is the hormone positive HER2 negative breast cancer acquired genomic instability during tumor evolution with ApoBac and HRD likely to be the main driver. Breast cancer with high level of ApoBac mutation are characterized by higher tumor mutation burden, and specifically lobular cancer, and mutation is PIK3CA, CDH1, NF1, P10, and patient with the ApoBac dominant ER positive HER2 negative MBC have a shorter PFS on the first line endocrine therapy, and patient with HRD dominant ER positive HER2 negative MBC have a shorter PFS with the first line endocrine plus CDK4/6 inhibitor therapy. Yeah, thank you so much for your patience listening.
Thank you, Dr. Deepak, for a nice presentation.
Thank you
Over
so
to
much.
Dr. Jagdeep, please.
So we will have sort of some discussion at the last of the topic when we have finished. My next speaker is Dr. Navdeep Singh. He is a medical oncologist at CCA, Ludhiana. So Navdeep, are you there?
Yes, yes. I'm in.
So you can take now. You can take the your session.
Kindly someone share slides, please, from the organization. Okay, I've been given this topic basically. It's an ICON trial. It's a phase 2B study evaluating chemotherapy combined with ipilimumab and nivolumab in metastatic hormone receptor positive breast cancer. We all know immunotherapy with checkpoint inhibitors targeting PD1 and or CTLA4. It has emerged as an important treatment modality in several cancers. So the tumor lymphocyte infiltration is predictive of predictive for the effect of chemotherapy in breast cancer. So this trial was conducted in hormone positive breast cancer because this approach has been largely unexplored. Next slide, please. Next slide. So coming to the study design of this trial. So the eligible patients were having metastatic hormone positive disease with HER2 negative, and maximum one previous line of with chemotherapy was allowed in metastatic setting, and there was no limits on previous endocrine and targeted therapy. So the patients, they were randomized to basically two arms. One arm was the chemotherapy only, and in the second arm, the chemotherapy was combined with IPLI and Nivo. So chemotherapy used was basically anthracycline, doxorubicin. So why they used anthracycline? Because anthracycline is considered as a immunogenic chemotherapy, and they have been found, anthracycline have been found to induce immunogenic cell death. The second chemotherapy they used is cyclophosphamide, which has been known to suppress cancer immunosuppressive cancer counter-regulatory T cells. So the dose used, pegylated liposomal doxorubicin was used along with oral cyclophosphamide. So they used pegylated to avoid steroids, limit heart toxicity, and to allow maximum time of treatment. So after randomization to these two arms, the effect was assessed for any toxicity and response. The primary endpoint was the progression-free survival, and the other endpoint was the monitoring. There is another cohort which again was taken from this study, which is only in which the only immunotherapy has been explored. Next slide, please. So coming on to the survival outcome. So when we see this, the PFS curve, so as we can see, there is you can see there is not a much difference between the both curves comparing chemo with chemo plus immunotherapy. The hazard ratio is 0.94. So the median PFS was 5.1 compared to 3.6 in combination arm compared to the chemo only arm, and it was not statistically significant. And you see, if you see the overall survival again, the arms are very close, the curves are almost overlapping. So the overall survival is again non-significant, not much benefit with the combination arm. It is 20.9 compared to 19.9 compared to the chemo only arm. So if you see that there is no PFS over overall survival advantage in the PD-L1 positive population. Next slide, please. Coming on to when you see the tumor response, I think this slide is not properly visible. I don't know. This slide is not properly visible. Can you go back to the back? Yes, this slide after the survival or tumor response. Okay, I will just share my slides. Just wait. Can you just stop sharing? It is visible?
Yes, sir, it is visible.
So coming on to the efficacy in the tumor response, if you see the overall response in the chemo-only arm, it is only 29%, as numerically slightly better. You can say 32% in the combination arm. And the clinical benefit was 48% in the chemo-only arm compared to 55% in the combination arm. So the responses, you can see there are slightly better responses, tumor responses. The partial responses are better in the combination arm, but again, it is not that much of a benefit. It is just a numerical benefit. When you see the safety and the treatment exposure, yes, the combination arm always have more side effects. So in the 65% in the combination arm, there are almost 65% had immune-related events. And median duration was 4.6 and 4.5 months in the combination versus the chemo-only arm. So you can see the endocrine immune-related adverse effects and the non-endocrine immune-related adverse effects. So more of the any grade 1 or even grade 3, these adverse effects were more common in the combination arm as compared to the single arm. But there was a association found between the immune-related adverse effect with the PFS. So if you see, if when the patient had a more than grade 3 for immune-related adverse effect, the PFS was better with a hazard ratio of around 0.34. So yet a lot of things to be explored in future about this combination. But at this time, this didn't increase any PFS, any benefit over immune-related adverse effects. So further biomarker analysis will be important. So for the basis of this study, certainly more of the studies is required in this perspective. Thank you.
So I think, can we have the next speaker, Dr. Suresh Patel? After all the abstract are finished, then we can go for some discussion.
Good evening.
Good evening. Dr. Suresh Patel. So Dr. Suresh, he is a medical oncologist at Capital Hospital, Jalandhar. So
Thank you, sir, for the kind introduction. Can you please share my slides? I would request you. So, good evening, everyone. My topic for today is phase 2 abstract, which was presented in ESMO Paris 2022. It is a randomized phase 2 trial of metronomic oral vinorelbine plus cyclophosphamide and capecitabine versus weekly paclitaxel as first line or second line treatment in patients with ER positive, HER2 negative metastatic breast cancer. The Meteor 2 trial. Next slide, please. So this is the slide of declaration of interest. So the background of the study was that patients which are included are histologically or cytologically confirmed ER positive, HER2 negative, locally advanced or metastatic breast cancer, measurable or non-measurable but radiologically evaluable disease according to RECIST 1.1 criteria, female more than 18 years of age with ECOG performance status of 0 or 1, no more than one line of chemotherapy for advanced or metastatic breast cancer, no more than 2 lines of previous endocrine therapy for locally advanced or metastatic breast cancer. Randomization was done in 1:1, and one group received paclitaxel-based chemotherapy 90 mg per meter square on day 1, 8, 15 every 4 weekly until progression or lack of tolerability. The other group received metronomic vinorelbine at the dose of 40 mg per oral daily on day 1, 3, 5 every weekly. Tablet cyclophosphamide at the dose of 50 mg daily continuous. Tablet capecitabine 500 mg, 3 tablets daily as a continuous treatment. And the primary endpoint was time to treatment failure. Secondary endpoints were PFS, overall survival, and also safety and tolerability according to NCI CTCA criteria. Next slide, please. So these were the patient characteristics in the Meteor 2 study. Total 140 patients were included in the study. Around The paclitaxel arm included 69 patients, of which 63 were initially assigned therapy, and 6 patients did not initiate therapy. So declined patients were 6. In the other arm of VEX-based therapy, 70 patients were included. 1 patient did not initiate therapy. So total out of 65 out of 70 patients discontinued therapy at database risk. And the patient subgroup analysis was done as per the ECOG performance status, age, type of available disease, ER status determination, prior treatment for the metastatic disease, prior endocrine therapy received or not. The interesting data to see was that around 47% of the patients were pre-treated with endocrine therapy plus CDK4B inhibitor based therapy. Next slide, please. So this was the primary endpoint, which was time to treatment failure. So as you can see, the Kaplan-Meier survival curve, which has a wider separation of the curve, and the median time to treatment failure in the VEX-based therapy arm was 8.3 months, whereas it was 5.7 months in the paclitaxel-based arm. The 12 months time to treatment failure was 34.3% in the VEX-based therapy arm, and it was 8.6% in the taxane-based arm, with a hazard ratio of 0.61, which was statistically highly significant, with a decrease in the mortality rate by 39% in the patients who received metronomic VEX-based therapy. Next slide, please. Next slide, please. So, previous slide, please. Previous. So the time to treatment failure in the efficacy analysis population, as per the subgroup analysis for prior endocrine therapy with CDK4 inhibitor based therapy, it was found that the median time to treatment failure in the VEX based therapy arm was 8.4 months, and it was 5.6 months in the other arm. And the 12-month time to treatment failure percentage was 25% in the VEX based therapy group, and it was around 8% in the taxane based therapy group, with a hazard ratio of 0.63. Next slide, please. So now we come to the PFS and overall survival. The secondary endpoints, it was found that the PFS was better in the arm which received VEX-based metronomic therapy, which was around 11.1 months in the VEX-based therapy arm, and it was around 7 months in the taxane-based therapy arm, with a hazard ratio of 0.67. That is a decrease in the mortality rate by around 33% in the patients who received VEX-based therapy.
I request you to conclude your presentation in 1 minute. Thank you.
However, the overall survival was not statistically significant, with a hazard ratio of 0.9. So when we come to the adverse events for patients prior to time to treatment failure, it was found that the frequency of targeted grade 3 adverse events was higher in the VEX group. Obviously, it was 3 regimen based therapy, which was 42.9%, whereas it was around 29% in the paclitaxel based group. The adverse events found were in the form of hand-foot syndrome, alopecia, nausea, and sensory neuropathy. So my conclusions are VEX significantly improved the time to treatment failure compared with paclitaxel. The median time to treatment failure was 8.3 months versus 5.7 months. More notably, the 12-month time to treatment failure was 34% versus 8.6% in the taxane-based group. Results for PFS and disease control were consistent with those for time to treatment failure. There was no difference in overall survival. For 5.6% of the patients, the time to treatment failure event reason was progression of disease. For 23% of patients, it was adverse events. More patients assigned VEX had at least one grade 3 plus targeted adverse events. Neutrophil count decrease was the most frequent adverse grade 4 event. Alopecia grade 1 to 2 was reported in only 33.4% of the patients with taxane. However, it was only 3% in the metronomic therapy based group. So Metro 2 successfully met its primary endpoint, showing that the metronomic VEX significantly improved time to treatment failure compared with the paclitaxel and should be considered as an option in the patient requiring chemotherapy-based therapy. Thank you. Next
Thank you, Dr. Suresh. So, Raman sir, are you there? So,
I'm here.
Sir, can you have some quick questions with our speakers, Dr. Suresh, Dr. Navdeep, Dr. Deepak, if any doubts, because we have to be in time limits.
Yeah, I understand that.
Yes, sir.
Say, I had the opportunity to read something regarding the mutational analysis. I request everybody to go through an article in journal Nature 21 to clarify. Say, honestly, I didn't have the opportunity to go through it before that. I know about PIK, 3CA and others. But what is happening? Is it just cytosine? And is it what kind of things further within that at the loop? That's what say DNA loop. Now, medical oncologists have to find something where they will be heavily dependent upon pathologists or molecular oncologists. We must know our limitations. Or we have to come via MSc science and then go to the medical sciences. That was one observation. So since when we read and what you read, there is a lot of difference. And how well we are training ourselves, that is going to be another observation. See, we are trying to find more and more pathways, more and more mutations. And all are linked to gradually therapies. And then it takes 5 to 10 years to find one kind of therapy and its efficacy. That was one thing from my side. And regarding the third study, I can say that we have to define that once OS is also available and PFS is also available, within the group, how we want to take it up. And secondly, where it is an advanced or metastatic disease, without a QOL, just by based on 2.5 months of PFS difference. So how you define that? Because some of the side effects which I know now after the presentation, that they are a little bit more on one side. And if other is on not on that side, no, what is going to the carry on things? Better thing is that it is oral. But some how we conclude that? So that is going to be another observation from my side. And I look towards comments from my other colleagues also.
The other thing is that when we are treating these hormone positive patients with this immunotherapy and with the metronomic chemotherapy, so how we are placing when we have a CDK4/6 inhibitors in our basket, maybe when we have the gene analysis of like the most important resistance to the hormone therapy is ESR1 gene. If I think I have not seen any test here in my setup who's doing this testing. I think ESR1 is not available if I'm not wrong. So we are not able to sort of find the things which exactly lead to the resistance of. There are a lot of now in that genomic stability, there are some 3-4 more genes which are going to do all these things. They are going to bring that resistance, and we might be able to focus on some other therapies, like on the ApoBec base, some signature, some mutations, or HRD, which was in there initially in the ovaries, and HRR in prostate. Maybe HRD may take some role in future in patients with the breast who are now having some other form of resistance to the hormone therapy.
You said it is less than 50% who used CDK4/6 inhibitors, which was at the presentation I pointed out differently, that how you interpret them. So it is studying in between the lines also that when we are trying to make, are we talking about after use of this or before use of CDK4/6 inhibitors?
Actually, in the third study, it was some subset analysis that is post CDK4/6 inhibitors. That exactly the study is like still phase 2 study, and we have to have a lot of phase 3 data on this. If we have to comment whether it has to be given pre or post to CDK4/6, that might define a better.
And second, it is only about one kind of metronomic therapy only.
Yes.
So we are not talking about other things where you can perhaps reduce some things or take away or add something.
Yes, sir. So thank you, sir. Can we have the next session? Dr. Jatin is there. So, Dr. Jatin is there. Good evening, sir.
Good evening, Jagdeep, and very good evening, Raman sir. Seeing you after a long time. Very nice to see you. Yeah.
So
can I share my presentation?
Dr. Jatin, he is our senior oncologist, and he is like another pillar and authority in oncology. So needs no introduction. Sir is a director in the medical oncology at IV Hospital, Mohali. Sir, over to you, sir.
So we'll be talking about targeting HER2 low expression in breast cancer. Now we have expanded our horizons.
Slides of full screen. It's not a full screen.
Sorry.
Yeah.
Are they okay now?
Yes, sir.
Okay. And I am audible?
Very much.
Yeah. So we'll be talking about HER2 low breast cancer. So we hardly used to worry or see the reports when HER2 was 2+ FISH negative, or HER2 was 0, or HER2 was 1+. But now we'll be looking at these reports importantly, because a new trial, Destiny 04, involving antibody drug conjugate trastuzumab deruxtecan has come, which will probably in future lead to a paradigm shift in how we treat our such subgroup of patients. So my content of my presentation are molecular subtypes of breast cancer, identification of HER2 low and unmet need in such cases, targeting HER2 low with TDXD. I'll be saying TDXD now. And that is about the Destiny Breast 04 trial, the rationale mechanism of action, study design, efficacy analysis, and the safety data. So these are the various proportion of molecular subtypes we commonly see. Maybe a bit of variations in our country. HER2 negative HR positive, that is luminal A, which is the best prognosis, it's 66.6%, and HER2 positive HR positive is 9.7%. HER2 positive HR negative is 4.3%, and HER2 negative HR negative, that is triple negative, is 10.8%, which is considered to be the worst one. So majority of breast cancers are HER2 negative and HR positive. So, and this is how the 4-year survival estimate of various subtypes, and Howlett et al. Analyzed data from 17 cancer registry in US to determine breast cancer specific survival by molecular subtype. So HR negative, HER2 negative, HR positive, it was 92.5%. HER2 positive, HR positive was slightly lesser, 90.3%. HER2 positive, HR negative was 82.7%, and HER2 triple negative was 77%. So patients with HER2 negative, HR negative disease have the worst prognosis again and again. So this is how we evaluate HER2 expression. It is mainly done with IHC assay, and in this particular trial, it was the Ventana which was used, and if there is no staining or incomplete or faint staining or of perceptible membrane staining in less than 10% of tumor cell, it is IHC 0. Incomplete, faint, barely perceptible membrane staining in more than 10% of tumor cell, it was IHC 1+, and weak to moderate complete membrane staining in more than 10% was IHC 2+. So IHC 2+ is considered equivocal, and if it is FISH negative, then it is called HER2 negative. So what is HER2 low? HER2 low is these 3 subtypes on the left hand side. So the one considered HER2 negative are the subgroup which we'll be talking about, 80 to 85% of breast cancer currently classified as HER2 negative and are not eligible for HER2 targeted therapy. Currently available HER2 targeted treatments have not proven effective in patients with low levels of HER2 expression. We all know that. So current HER2 classification, now it's HER2 negative is considered HER2 low, and they are more frequently found with HER2 negative HR positive tumor. That is, HR positive are more HER2 low tumor, 65%, compared with HR negative, which is 37%. So this is the current guidelines. Around 60% of MBC has HER2 negative express low levels of HER2, which is clinically meaningful. And this is the current paradigm. So now, this particular study, this was conducted all over the world, and there were 93 patients from America and 250 patients from rest of the countries. And standard of care prior to Destiny Breast 04 was simply that you have to use in HR plus, you use metastatic in HR plus, you use endocrine therapy combinations, may use PARP inhibitors, and in HR negative, you had checkpoint inhibitors, you had PARP inhibitors, and currently now we have secukinumab govitecan. Not much relevant in Indian scenario because of its prohibitive cost. And finally, both of these subgroups finally landed up with patients undergoing chemotherapy finally. So what is TDXT? TDXT is an excellent antibody drug conjugate, and the key word or the key characteristic of this particular molecule is the bystander effect. TDXD is antibody drug conjugate with a cleavable linker, and it has a highly top 1 inhibitor payload, and there is 8:1 drug to antibody ratio. You can see in this particular cartoon that TDXD binds to HER2, internalized, the linker is easily cleaved, releasing top 1 into this, and top 1 inhibitor enters nucleus, and membrane permeable payload results in bystander effect. It also goes into the neighboring cells because this top 1 particularly is membrane permeable. So it is this bystander effect that has led to the usage of this particular drug in HER2 low subtype. So this was the Destiny 04 trial. It was a multi-center open label phase 3 study, and if the patients were HR positive, the disease must be considered endocrine refractory. TDXT was used in the dosage of 5.4 mg per kg every 3 weeks, and it was a randomization was 2:1 in favor of TDXT. The treatment of physician choice, you can see these were the molecules, though not the complete list of molecules we use in our day-to-day practice, but mostly covering most of the important molecules: capecitabine, eribulin, gemcitabine, paclitaxel, nab-paclitaxel, and so on. So the primary endpoint was PFS by independent review, and secondary endpoints were PFS for all the patients. The primary endpoint was for HR positive. Secondary endpoint was PFS by BICR all patient. Overall survival, HR positive and all patient, health economics and outcomes research, and quality of life. So stratification factors were centrally assessed HER2 status, 1 versus 2 prior lines of chemotherapy, and HR positive with versus without prior treatment, CDK4/6 inhibitor versus HR negative. So primary analysis for PFS planned after at least 318 event at data cutoff of Jan 11, 2022, there were 321 and 370 BICR-SS PFS events in HR plus cohort in all patients respectively. And At data cutoff, 61 patients remained on treatment, out of which 58 were on TDXD and 3 were on treatment of physician choice, and median follow-up was 18.4 months. And OS analysis, 199 events were there in HR positive cohort and 239 in all patients. The inclusion criteria were mainly age in majority, age of majority in respective country, pathologically documented breast cancer that is unresectable or locally advanced or metastatic, and previously treated 1 to 2 lines of chemotherapy, and documented radiological progression of disease, and protocol defined adequate critical organ functions. So exclusion was ineligible for any treatment of physician choice, history of HER2 overexpression. If there was a history of HER2, they were not included in the trial. Prior treatment with anti-HER2 therapy, they were not included in the trial. Uncontrolled or significant cardiovascular disease, and medical history of ILD or pneumonitis. Spinal cord compression or active CNS metastases that are untreated and symptomatic or require therapy to control symptoms were also not included. As you can see, the demographics, they were equally distributed between both the arms, and so was the HR status, and the hormone receptor positive status was also equally, because it was 2:1 randomization. The percentages are always, the numbers are always more in TDXD arm. Liver metastasis at
I request
baseline.
you to conclude your presentation in 1 minute.
Visceral metastasis were. So these were the various lines of systemic therapy. As you can see, in mostly more than equal to 3 lines of therapy were there. So it had a very good effect in subsequent line of therapy. So as you will see, and also as for the CDK4/6 inhibitor, around 70% of patients in TDXD, and same in around treatment of physician in HR positive patient was used CDK4. So this was the PFS, 10.1 months of PFS in hormone receptor positive, 9.9 months of PFS in hormone receptor, all patients, HR positive and HR negative taken together, hazard ratio of 0.5 in 0.51, 0.50 in both the arms. And all subgroups benefited, as you can see from this, whether it was a visceral disease or not a visceral disease, and what was the performance status, less than 65, more than 65, prior CDK4/6 or no prior CDK4/6, equal benefit. If it has not been used, then the hazard ratios were even better. And the median OS, unprecedented median OS, 23.9 months of median OS versus 17.5 in treatment physician. This was for hormone receptor positive. Hazard ratio was 0.64. And all patients also, the 23.4 months, and hazard ratio was around 0.64. PFS in hormone receptor negative was lesser, 8.5 months, but the hazard ratio was excellent, because hormone receptor positive and treatment of physician choice didn't fare so well. And OS in hormone receptor positive was slightly lesser, again, because treatment of physician choice didn't perform really well as in hormone receptor positive. These are the various figures. I won't go into the detail, but look at the waterfall graphs. As you can see, the best changes in targeted lesion, the response rates, and everything was much better in TDXD arm compared to treatment of physician choice. The adverse events, if you see, the most contentious adverse event in this was ILD or pneumonitis related to TDXD, and grade 5 TDXD was lesser as against various previous trial with the TDXD, because we have the investigator have learned how to foresee this event and do various drug interruptions or drug reductions and all this stuff. So total on treatment deaths in TDXT were 14 patients, and treatment of physician choice it was 8 patients. So on treatment deaths due to treatment was just 3.8%, nearly similar. Most common with dose reduction was also lesser in TDXT arm. Yes, for treatment discontinuation, ILD or pneumonitis, TDXT was more responsible. And this was ILD related thing. Any grade 12.1%, grade 5 just 0.8%, and mostly they were grade 1 and 2, easily manageable. And left ventricle dysfunction also, any grade 16%, and cardiac failure was seen in, any grade was 4.3%, and cardiac failure was seen in 0.5%. So this was the efficacy analysis that has become, it has been approved as a new targetable agent in HER2 low patients. And as far as the quality of life thing is concerned, again, they have shown that it was maintained as against the treatment of physician choice, and FDA approved first targeted therapy for HER2 low breast cancer. So it's absolutely a new paradigm. And this has been a category 1 recommendation in NCCN for HER2 low metastatic breast cancer. Thank you.
Thank you, sir. Raman sir, can we have one quick question or any comments from your side?
See, we need to understand, that's what I say, that with these things, will it be valuable to use HER2 at all if it is efficacious everywhere? So are we looking towards including HER2 negative also gradually? See, it is the beginning of the development of molecules which are going to lessen the dependence, the way we have learned. Like I remember the days when we were giving tamoxifen to everybody, irrespective of the hormonal status. Gradually, the knowledge increased and this happened. So perhaps this is the beginning.
Yeah, this is the
side.
beginning when we feel that the current testing methods are inadequate to check the minimal, as we say, the sensitivity to detect even the minimal HER2 receptor status in the breast cancer. So maybe in future you might have some more sensitive tests to detect such things.
Dr. Jatin, this reminds me that even for hormone receptor positivity also, there was a criteria of 10%, and then it was 1%.
Yeah.
And then it was truly negative. So we are going to witness that perhaps quantification not only within 1, 2, 3.
Yeah.
There is going to be further subdivision, and we should keep our eyes open and whatever pours in the literature.
Yeah, definitely. Definitely.
Thank you, sir. Thank you, Jatin. So our next speaker is Dr. Chitresh Agarwal.
Thank you, Jatin. Thank you.
Thank you.
So Chitresh, are you there?
Jatin sir, you need to stop share your screen.
Yeah, just doing that. Okay. Okay. Yeah. That's fine.
Yes, sir.
So I can see the Chitresh here. So Chitresh.
Good evening, Dr. Jagdeep. Thank you for the slides so that I can start my presentation.
Yes.
So good evening, all of you. The topic assigned is redefining the management of HER2 negative early breast cancer. Next slide, please. So the content includes the background, role of BRCA mutation, targeting BRCA mutation in EBC, and the summary. Next slide. So over a quarter of people with EBC will have their cancer return. Breast cancer, as we know, is the most common cancer worldwide. 20 to 30% will recur where cure is no longer possible, and 9 to 10% with HER2 negative disease actually have a germline BRCA positivity. Next slide, please. So in 2020, up to 30% patients in India, they present with early disease at diagnosis, and higher rates of early breast cancer at diagnosis were seen in USA in comparison. Next slide. So this is not we'll discuss in the end of the presentation rather than discussing it. So move on to the next. So this is the changing landscape of HER2 negative early breast cancer management. And without going into details of which, we know that now in early breast cancer in adjuvant treatment, we have some data to support the use of pembrolizumab, atezolizumab, abemaciclib, and adjuvant capecitabine. And with increasing evidence, now we know that BRCA mutant HER2 early breast cancer is also increasingly being recognized as a unique disease that can be targeted with the PARP inhibitor treatment. So in backdrop of this, we will see the data that I'm going to discuss. So next slide, please. So patients with BRCA mutant early breast cancer, they have a distinct tumor characteristic compared with the sporadic population. So BRCA mutant breast cancer is characterized by more aggressive phenotype than the sporadic disease. They are of higher grade, they have more CNS metastasis, and they have more contralateral oblique ipsilateral disease incidence than the sporadic population. Next slide, please. So the targeting treatment to optimize patient care, approximately 5 to 35% of breast cancer patients, they harbor a BRCA mutation, and BRCA mutations, as we all know, are more prevalent in the triple negative breast cancer than in hormone receptor positive breast cancers. Next slide, please. So the prevalence of pathogenic mutations in breast cancer patients is actually higher in Indian patients compared with most other populations. Among the 59 TNBC genomic DNA samples sequenced, BRCA mutations were identified in around 13.6% of the patients. So what we know is that data is available to suggest that 50 to 80% of the individuals at risk of having a hereditary breast cancer are actually never tested because they do not meet the current criteria for the testing. Next slide. So in the early breast cancer setting, upfront knowledge of BRCA is very important. Why? Because it not only helps in the decision-making during surgery, but it also nowadays helps us in choosing the best adjuvant treatment that we can offer to our patients. Next slide. So the preoperative genetic testing, it impacts the surgical decision-making in patients with BRCA mutation, because if we know the BRCA status beforehand, we most of the patients, they would actually going up for contralateral prophylactic mastectomy if we are already aware of the BRCA mutation status. And if we see this slide, it is very interesting, because if it is already known that a patient is BRCA mutation positive, 76.4% of the patients would actually undergo a contralateral prophylactic mastectomy, whereas if the BRCA mutation status is unknown, then only around 15% of the patients would be undergoing contralateral prophylactic mastectomy. So that is a significant difference. Next slide, please. So this is the main trial that is in the early breast cancer setting, Olympia. This is a phase 3 study of olaparib versus placebo as adjuvant treatment for high-risk germline BRCA mutated HER2 negative breast cancer. The eligibility criteria for this trial included germline pathogenic BRCA1 or BRCA2 mutation, stage 2 or 3 breast cancer, HER2 negative, and patient has completed local treatment and more than equal to 6 cycles of neoadjuvant or adjuvant chemotherapy containing anthra and taxanes. Now in the neoadjuvant group, TNBC patients who had achieved non-PCR or HR positive non-PCR, and a CPS plus EG score of more equal to 3. I would show you what is CPS plus EG score. In this setting, they would go for neoadjuvant chemotherapy, surgery, and RT as required, or adjuvant group where TNBC more than equal to PT2 or PN1, or HR positive disease with more than equal to 4 lymph nodes, again surgery, adjuvant chemotherapy or RT. They were randomized to receive olaparib 300 milligrams BID or placebo, and the primary endpoint for this trial was IDFS. Next slide. So the high-risk criteria according to Olympia trial for triple-negative breast cancer patients, it was if treated with adjuvant chemotherapy were required to have axillary lymph node positivity or invasive primary tumor measuring at least 2 centimeters on pathology. And if treated with neoadjuvant chemotherapy, they were required to have residual invasive breast cancer in the breast or resected lymph nodes. That is, they have not achieved a PCR. If the patient was hormone receptor positive, then if treated with adjuvant chemotherapy, they were required to have at least 4 pathologically positive lymph nodes. And if treated with neoadjuvant chemotherapy, they were required to not have a PCR or a CPS plus EG score of 3 or higher. So what is this CPS plus EG score? Now, CPS plus EG score actually provides a more refined prognostic categorization of patients with breast cancer after neoadjuvant chemotherapy versus clinical or pathological staging alone. So CPS is clinical stage, pathological stage, is the receptor status and the nuclear grade. And the combination of these, we will see that it is sum of point scores of clinical stage plus pathological stage plus ER receptor status plus nuclear grade. And it is a total score of 6. So anything which is more than equal to 3 would actually be classified as a higher CPS plus EG risk group. Next slide, please. So patients with a higher CPS and EG scores, they relapse earlier than those with lower scores because the risk of disease is actually higher in higher CPS plus EG groups. Next slide, please. So the baseline characteristics, they were well balanced between treatment groups. Next slide. Next slide. And if we see here, we will see that versus 77.1%, and the absolute difference here was 8.8%, and the hazard ratio being 0.58, and it was statistically significant. Next slide, please. Slide, please. So over 7% more patients, so longer follow-up confirms DDFS benefit of adjuvant olaparib versus placebo, with 7% more patients free at distant recurrence at 4 years, and the DDFS was 86.5% versus 79.1%, and here the difference was 7.4%, which was also significant. Next slide, please. So olaparib demonstrated a significant OS benefit with 90% of the treatments alive, patients alive at 4 years in the olaparib arm. And here the 4-year OS rate was 89.8% versus 86.4%. And the absolute difference of benefit was 3.4%. And the hazard ratio being 0.68, but it was not statistically significant. Next slide. Incidence of second primary non-breast cancers was halved in patients who received olaparib versus placebo. And fewer patients in the olaparib arm actually had a CNS recurrence versus the placebo arm. Next slide. A consistent benefit was seen in all the IDFS subgroups, whether it was, patients based on prior chemotherapy, prior platinum sensitivity, hormone receptor status, or the BRCA status. And you see that all the subgroups, they favored the usage of olaparib. Next slide. Same. Next slide. Similar is the case with OS benefit, and OS benefit was derived across all subgroups, irrespective of the subgroup that we wanted to analyze. Next slide. So more than 70% of the patients completed treatment according to protocol without the need for a dose reduction. And this is actually very encouraging because I don't think that in our clinical practice, at least in my clinical practice, I am able to achieve such a high rate of continuation of olaparib. But this trial, this data, it showed that more than 70% of the patients were actually able to complete the treatment protocol. Next slide, please. 10% of the patients, they discontinued treatment due to adverse events, and the most common adverse events that emerged was nausea and anemia, with nausea being around 2% and anemia being 1.8%. Next slide. Adverse events were mostly mild to moderate in the olaparib arm. And as I have previously mentioned, that most of the patients ended up having nausea and anemia as the most common cause. Next slide, please. So what were the most common events observed? So the most common events observed were nausea, fatigue, anemia, vomiting, headache, diarrhea, neutropenia, leukopenia, decreased appetite, dysgeusia, dizziness, and arthralgia. And anemia was the only grade 3 adverse event which occurring in more than 5% of the patients. Next slide, please. Blood transfusions were infrequently required, and majority of the patients required only one blood transfusion during this treatment protocol. Next slide, please. 1 year of adjuvant olaparib maintained global health status HRQL versus placebo, and there was, if you see, there was not much difference in the quality of life of these patients on treatment. Next slide, please. There was no clinically meaningful change in fatigue severity score across the duration of the study, and fatigue was the primary pro-endpoint in this. Next slide. Next slide, please. So there was no clinically meaningful difference between olaparib and placebo for physical or emotional functioning subscale over time. Next slide. So the targeted treatments in early breast cancer have improved event-oblique disease-free survival. Overall survival improvements have been documented by a few currently. And as we have seen, the case of trastuzumab, same is the encouraging result of olaparib in this subgroup of patients. Next slide, please. So coming to the treatment algorithm for HER2 negative early breast cancer patients now in 2022, after learning about Olympia trial, high risk HER2 negative early breast cancer, randomization to see whether they were TNBC or HER2 positive. If TNBC, whether they are BRCA mutant or they are BRCA wild type. If a patient is BRCA mutant, we should offer adjuvant olaparib for 1 year. If they are BRCA wild type, we should consider adjuvant pembrolizumab, or we should consider adjuvant capecitabine for 6 to 8 cycles based on CreateX data. If it is HR positive, HER2 negative, and we know that the patient is BRCA positive, then adjuvant olaparib for 1 year plus endocrine therapy. And if it is BRCA wild type, then adjuvant abemaciclib for 2 years and endocrine therapy endocrine therapy continuation. So to conclude, Olympia trial was the first to report the clinical benefits of a PARP inhibitor olaparib as an adjuvant treatment in patients with BRCA mutant, HER2 negative high risk early breast cancer, with 9 to 10% more patients recurrence-free at 3 years. 1 year adjuvant olaparib significantly reduced the risk of recurrence of death by 42% in comparison to placebo. Adjuvant Lynparza resulted in patients living longer with a 32% reduction in risk of death. It was consistent with the previous studies. The safety profile of olaparib was limited and manageable, and the test of BRCA mutation at diagnosis to inform treatment decisions and maximize long-term outcomes is mandatory nowadays in early breast cancer. Thank you.
Thank you, Chitresh. So, Dr. Jatin, can we have one quick question from your side or input from your side? I think Dr. Jatin, Dr. Raman, sir, or Dr. Jatin is there. So, can we have one quick input from your side?
My side, are we practicing everybody in the group early breast cancer is not triple negative, means HER2 means hormone receptor positive. We need to essential aspect of its practice if you understand about it. So those things are going to be important. One is testing itself. Are we doing it for 100% of people? And how about the treatment thereof? And if patient can't afford treatment, how often we are not getting it done? This has to be clear in our own mind. I leave it on to the judgment of all the participants.
Dr. Jatin, sir, from your side?
Well, I would say this is an important trial, and especially for early TNBC, I would say it is an important trial, and for those not having PAT-CR and having BRCA mutation positive, I think But again, the trend is towards increasing the overall survival, but we need to see further more results. But yes, we are testing BRCA mutations in our breast cancer. Yes, we have started testing, especially if the female is young, even in ER positive. I have started this training.
Good evening, Kunal sir. I can see you on the board. And good evening, Dr. Anuba.
Yeah, I just wanted to make one comment. I think, good evening, Dr. Anuba.
Hi, good evening,
everyone. So I think it is important, considering our setup. Not everybody will be able to afford these high-end molecules, especially when generics are not available. But I think testing wise, there are two aspects of testing. One is for therapy anyway, but the other aspect for testing is also for considering things for the patient and for the family in terms of whether they need bilateral helping oophorectomy. So I think that aspect is very clear. Testing wise, yes, triple negative with strong history, and especially in young, definitely testing will be there, but very small percentage, I would say, would go on to have adjuvant therapy. I haven't given to anybody so far.
So basically, it is to screen the patient's family for the germline testing, germline mutations. So thank you, Dr. Chitresh. So next session is by Dr. Anuba. She is a medical oncologist and hematologist at a particular hospital, Jalandhar. Her topic will be mastering the evolving treatment landscape in the HER2 positive breast cancer, current guidelines and future perspectives. Over to you, Dr. Anuba.
Thank you so much. And I really thank Dr. Jagdeep and the organizers for giving me this opportunity. I hope I'm audible. So quite an extensive topic, and it was mastering the evolving treatment of HER2 positive breast cancer. And I must say that this discussion so far have been really interesting, and a lot of points as regard to our Indian population has really been brought up, which is what is, I think, important and the part of such discussions. So far, we know that a number of US FDA drugs are approved for HER2-targeted therapy. And while 3 of these are currently available and in the reach of, I would say, a majority of our patients, most of these, especially the ones that have come in the last couple of years, I don't know when they will be here, but it's definitely interesting to hear how they have been game changers in the management of HER2-positive disease. So we're all cognizant of the fact that HER2-positive breast cancer patients, the disease is a little more aggressive. These patients are younger, and especially if you don't use targeted HER2 therapy, they do have a poorer prognosis. So what is our game plan? How do we make decisions depending on where and when the patient comes to us? And I thought that we would look at the data for use of HER2-targeted therapy in neoadjuvant, adjuvant, and metastatic setting. So all of us, are quite familiar with the use of adjuvant trastuzumab in HER2-positive breast cancer. This was introduced in 2005. And as Dr. Chitresh rightly pointed out, that the benefit in DFS and OS is anywhere in the tune of, 9 to 11% across the various trials. And again, something we're all comfortable with. The generic versions are available. The costs have come down. And I think it is rare that there is a patient who does not accept therapy. In fact, there are various NGOs who will also pitch in and help when there is somebody who needs adjuvant trastuzumab. But science is rapidly evolving, and I think the treatment or the use of these targeted therapies is moving up, higher up in the treatment of these patients. And now we all, and majority of us, would try to use neoadjuvant therapy when we are treating a patients with HER2-positive breast cancer. So the indications, basically, we know that locally advanced patients, it's a no-brainer, you'd use it. But more and more, there is very strong evidence that even early stage breast cancer that are clinical T2 or a clinical N1 or even a T1C, those are the patients too that we need to have a discussion with the patient and our surgeon and talk to them about the role of HER2-targeted therapy for these patients, especially if we are considering conservative breast surgery, if the patient has a larger tumor in relative to their breast side, if there is limited axillary nodal involvement and you want to avoid the morbidity of axillary lymph node dissection and plan for sentinel lymph node. And now with the data of TDM1 used for residual disease in the adjuvant setting, again, it makes more sense to use trastuzumab with or without pertuzumab in the neoadjuvant setting. And as Dr. Chitresh also rightly pointed out, that now sometimes we would want to know the BRCA status upfront. So if we are getting genetic testing and it's going to take some time, there is a little bit delay in definitive surgery, it makes more sense to start off with the neoadjuvant therapy. We all realize that the response to neoadjuvant therapy, especially the achievement of PAT-CR, is significantly associated with improvements in DFS and OS. So it's both prognostic and predictive. The regimens, again, all of us are quite, we are quite familiar with the regimens. And what we have learned over the last couple of years is that really dual HER2 blockade has given us a higher and higher PAT-CR with, multiple trials I've put up for you here. But what we have seen is if we are using a combination of trastuzumab and pertuzumab with a chemotherapy backbone, we are almost going to get, 70 to 75% chance of having a significant response and having PAT-CR. So again, costs allowing, that would be the choice, a combination of a taxane with trastuzumab and pertuzumab. But again, we wanted to talk about what things are coming new in this setting. And there are certain things that are being evaluated. What about the use of TDM1 in the neoadjuvant setting? The data is conflicting. There are some studies in favor of it, some studies not so much in favor of it. So right now, maybe in the next couple of years, we'll have some more, somebody will weigh in. But currently, I don't think TDM1 would be used in the setting. Neratinib is also something that has been studied in the neoadjuvant setting. We have one trial in favor, the I-SPY2, one trial that did not show much of a difference. But the two things I think that have, again, changed for us is the use of, subcutaneous trastuzumab and pertuzumab. Definitely, while all of the trials included IV trastuzumab and pertuzumab, we know that there is a significant wait times. And I know that there will be a talk further down in this program today talking to us about the combination Fexo. And I think the other thing that has been a game changer in neoadjuvant chemotherapy is, of course, the biosimilars, which we have discussed, have brought down the costs of getting neoadjuvant therapy. So as of today, I strongly believe that anybody who has a T2N1 disease, and even those, some of them who have T1C, and they have HER2 positive breast cancer, they should be a candidate for HER2 positive directed therapy. And again, now I think with the dissemination of information, more and more surgeons are buying into this and sending us the patients before doing the surgery for discussion for neoadjuvant chemotherapy. So what about responses? This was again highlighted in Dr. Jatin's talk about, looking at the molecular subtypes. Sometimes you are able to predict what are the chances of having a PAT-CR. Again, I would say the science is in evolution, but we do know that hormone positive, lesser chances of having a PAT-CR. HER2 positive, but not HER2 enriched, they're also likely to have a less chance of having a PAT-CR. If they are PIK3 mutated, lesser chances of achieving a PAT-CR. Hormone negative, and also those with tumor infiltrating lymphocytes, which we know also can predict for responses of improved rates of PAT-CR. So this is something that is probably we'll hear more from in the coming few years. The other thing that was pretty interesting that I came across this year was data from this study, the WSG ADAPT HER2 positive, HR negative patient subgroup, where they tried to de-escalate therapy in the neoadjuvant setting. And they said that really, do we need to do chemotherapy here? Can we get away with just doing dual HER2 targeted therapy? And it was interesting that in this subgroup of patients, really the results were very, very good. And even without giving the paclitaxel backbone, the 5-year invasive disease-free survival was not significantly different. And the OS also, there was no difference in survival. So again, this is something that we may be hearing of in the future, especially when we are wanting to de-escalate therapy, again, for your older patients who are more comorbid, etc. Something to think about. So what about the patient who has already undergone surgery and we are talking to them regarding adjuvant therapy? The way that I guess most of us look at these patients is whether they are high risk for disease recurrence versus low risk for disease recurrence. So who is high risk for having a recurrence of disease? I guess anybody who has residual disease, or if they haven't had a neoadjuvant therapy and they've gone for surgery first, anybody who's node positive, having T3 or T4 disease with any N+. So what would be the best regimen for these patients, and what have we added on to trastuzumab to improve their survival and the disease-free survival overall and disease-free survival? So there are, I would say, 3 ways of looking at it. We know, we'll talk about them one by one. The use of TDM1 for those who have residual invasive disease after neoadjuvant trastuzumab, neoadjuvant taxane and trastuzumab. We also know about the addition of pertuzumab to trastuzumab in the adjuvant setting. And I'll talk a little bit about neratinib for those who are hormone positive and the XDNet study. So again, Catherine study, something we are all familiar with, we've all bought into. And basically, it did show to us that using TDM1 rather than trastuzumab for patients who have residual disease, there is an improvement in 3-year IDFS of almost 11%. And I would say that for the patient who can afford it, this is definitely something that all of us would offer. What about the addition of pertuzumab to trastuzumab to somebody who has not received neoadjuvant HER2-directed therapy? This is a little bit, for me, it's a little bit harder to argue when explaining to our Indian patient, because as you can see here, at the 3-year, there wasn't that much of a difference in IDFS. But yes, at 6 years, there was a 2.8% difference at IDFS. So probably the patient that I would pick this drug for, i.e. the combination of trastuzumab and pertuzumab to chemotherapy, would be for those who are node positive, because as you can see here, those who are node positive have an almost 4.5% difference in event-free rate at year 6. So when we are talking to our patient, this is probably the data I would quote. However, again, in our Indian subtext, this adds a lot to the cost, and it's something that, most patients, it's really hard to explain to them, or they do agree to take this drug. So neratinib, I have not had the opportunity to use it, and perhaps our faculty can talk to us if anybody has had the opportunity. But this also was a very interesting study where they showed in almost 3,000 patients with HER2-positive early-stage breast cancer who had received trastuzumab were randomized within 1 year of prior trastuzumab to a year of neratinib. And what they were able to show is that definitely for the HER2-positive, hormone receptor positive, there was an absolute benefit of almost 5% in invasive disease-free survival at 5 years, and an absolute survival benefit about 2%. So again, something to think about for the high risk hormone receptor.
I request you to conclude your presentation in 2 minutes.
I thought I had 20 minutes. That was the time that I had been given.
Okay.
So yeah. So anyway, neratinib, I won't go into this because of time. The complications are something to really think about. What about the low risk HER2-positive early breast cancer? This would be the patient who has less than 2 centimeter disease without any positive nodes. And here again, we can de-escalate therapy and do adjuvant paclitaxel with trastuzumab. This is something I think a lot of us routinely offer our patients. They do look at TDM1 in the low-risk patients. However, when you compare the results to that of the APT trial, are not very impressive and a higher rate of discontinuation. So again, something that has not really been relevant for clinical practice. Maybe if you want to avoid paclitaxel or somebody who's at a high risk for the toxicity of paclitaxel, this could be something that we could consider. So moving quickly to metastatic disease, again, all of us know of how trastuzumab changed survival for patients with HER2-positive metastatic breast cancer. But what is there over this today? And I will briefly go into all of the trials, but in short. So when we look at these patients with metastatic disease, I think the question to ask ourselves is whether they've been treated, or are they treatment naive, or have they received adjuvant therapy, and have they received HER2-positive therapy at any point in their time? All of us are very familiar with the Cleopatra data for the chemotherapy and HER2 therapy naive patient, where we've shown that the combination of dual targeted therapy with docetaxel has a 16-month survival benefit. So definitely, if again, patient can afford, this would be probably the choice of our first line. But what about second line? And again, here we have very, very interesting data. We already heard about the Destiny 4 trial from Dr. Jatin, but here I'll talk to you about the Destiny 3 trial and how probably in the coming years, trastuzumab deruxtecan will probably overtake the use of TDM1 in the second line setting. And of course, a number of other TKIs that have come into this picture. And again, I'll briefly discuss the studies. So TDM1, of course, got its approval because it was able to show almost 5 to 7 months survival advantage over the use of lapatinib and capecitabine in the second line setting. But this data, this was really, really exciting. As we can see here, they randomized patients who had received previous therapy with trastuzumab and a taxane. And what the hazard ratio is so impressive, like, you know, it's a hazard ratio of 0.28. And I don't think I've seen many trials in the last couple of years which have shown such an impressive hazard ratio. So definitely a drug that, I guess it's a blockbuster drug, not available to all of us right now. And we also, Dr. Jatin told us about the toxicity of ILD, so something to think about. But it is something that will probably come up in the second line setting before TDM1. We've already learned from the previous trials the difference between TDM1 and TDXD, but the interesting thing here is really the bystander effect, which is why it is effective even in the HER2 low population. And in this heavily pretreated patient, more than 60% of patients had a response with a PFS approaching 20 months. So, you know, now we are at the point where we are giving, you know, multiple years to patients who have metastatic HER2 positive breast cancer. Drugs that we will probably see in the next couple of years in India also is the tucatinib TKI, which was evaluated in the HER2 CLIMB study, and it showed us, again, very good survival, even in those who have brain metastases. In fact, if we look at the data for overall survival for patients with brain metastases with this combination of tucatinib, trastuzumab, and capecitabine, you will see that there is almost a 10-month difference in median overall survival. So at 2 years, there are more than almost 50% of patients are still alive. And we do know that brain metastases is a poorer, patient with brain metastases tends to have a poorer survival otherwise. Neratinib and with capecitabine has also shown to be a little bit superior to lapatinib with capecitabine. And here we can see that there is a difference of about 2 months in overall survival. A drug which has margetuximab, it was compared with chemotherapy to trastuzumab plus chemotherapy. And here we have seen a hazard ratio of 0.79. Again, not a drug that we are all familiar with, but probably will be coming into the 3rd and 4th line of treatment of patients who have HER2 positive breast cancer. So given that we have this, I would say, plethora of drugs for HER2 positive breast cancer, how do we sequence? I think the sequencing is what is going to be important. First line, fairly straightforward for the de novo patient, is the Cleopatra data. But second line, probably it's going to be a fight between TDM1 and TDXD. And I do think that the trastuzumab deruxtecan is going to win this fight. And probably once it's available, more and more of us will be using it. And then we would look at a TKI combination with trastuzumab for somebody who has brain metastases. And of course, we do have more and more agents such as margetuximab and neratinib for the 4th and the 5th line. So a lot of drugs available. I guess we're a little bit short of time, so I will not go into each of the sequencing. But given the number of drugs, more than anything, I think sequencing, managing the toxicity, and maintaining the quality of life, which Dr. Raman really pointed out. You have to maintain the quality of life and make sure that you give the drugs to improve survival, but keep the quality good as well. So not much of a take-home message, except that we really should be offering HER2-directed therapy, if it's possible, a dual targeted therapy, escalate and de-escalate, depending on the response that your patient has had, and choose and sequence therapies appropriately based on patient's performance status, their comorbidities, the line of therapy, the drug toxicity, the presence of brain metastases, and most importantly for our Indian patient, the cost considerations. So thank you very much. Dr. Jagdeep, you're muted, I think.
Sorry. So thanks, Dr. Anwar. So basically, it's a very precise lecture, and starting from dual anti-HER2 therapy in the metastatic to the new adjuvant, then to the TDM1 in the early breast cancer and metastasis, and then TDXD, which is now a new drug in our basket. And this is a breakthrough for the patient who are having the brain metastasis for tucatinib or this TDX. So I think these drugs will be shortly available. Of course, prices are one of the challenges with us. And the tucatinib, at least we can get, sometime the patient can get from the some of other like, you know, from the Bangladesh, or they just one patient is I have one patient with the tucatinib. He got it from Bangladesh. So I think maybe down the line we will have all these drugs with us. Thanks for all your this lecture. Next is from Dr. Jatinder. So he is also medical oncologist at the Patel Hospital. So over to you, Dr. Jatinder. Dr. Jatinder, you are muted.
Sir, good evening, sir. Good evening to the seniors and the colleagues. And I'm audible to you, sir?
Yes, you are audible.
My screen is shared with you?
Yeah, no, it is still not.
Now it's shared with you?
Pooja, can you assist?
No, sir. Screen is not visible.
It's shareable, sir?
Yes, sir. Yes, sir. You need to make it full screen.
Okay. So as you know that the topic is going about the big molecules, like in HER2 disease, the new drugs are coming, and then the targeted therapies are also coming. But my topic is about the metronomic chemotherapy. It's the combination of the capecitabine and cyclophosphamide. As our Indian population, most of the people group belongs to economic poor conditions. So in a TNBC, we offer the metronomic chemotherapy to some people. So how it's evolved? What is the basic background about this? So what is the scope of this presentation? That the oral FD's combination of the capecitabine and the cyclophosphamide, and what is the rationale for that combination, and what is the concept for the metronomic chemotherapy? What are the data and challenges about this drug? And there is a study for that. Most of the studies are the phase 2, and the Indian studies was of the phase 2 and 3 result was there. And what are the advantages of the combination? So I'm concluded my talk with that. So in metastatic breast cancer, it is very difficult to treat the patient because most of the people are untreatable, and the metastatic breast cancer itself is not treatable. So most of the people get so many chemotherapies, and the list gets exhausted. After all, at the end, we give the metronomic chemotherapy. So chemotherapy is very effective in advanced breast cancer, but they are generally considered as they are considered most effective for the management of the. However, approximately one third of the patient fail to respond to the treatment with the anthracycline and taxane-based metastatic breast cancer. So treating that patient is very significant challenge to the medical oncologist. So how it evolved? There is a in first 2007 in the New Zealand and Japan, there was a study was there for the combination of the drugs, and the SWAG was the first study in the Japan. There is a combination of metronomic chemotherapy. Then there are big Europe combined studies was there for the PANLO project detailed. And then in India, the INCLOSE studies was there, which was the phase 2 and 3 combination trial is there. So why capecitabine was preferred in this study? It was a highly single agent activity, having a unique safety profile, having a no alopecia, low incidence of the side effect, low myelosuppression was there. The drug is available with the other combination, and the data and efficacy of this drug are good. So what is the rationale of the combination? There is a combination that the capecitabine, as you show in this cartoon, the capecitabine is detoxifying the liver, and the 5-FU was there. So the cyclophosphamide added with the capecitabine, it synergizes the effect of the thymidine phosphorylase. So the capecitabine can act very good with the combination of the cyclophosphamide. So what is the mechanism of this in the breast cancer? It directly kills the cancer cell. It is having an anti-angiogenic effect. It is having an immunomediated effect and the endocrine effect also. So the drug have reached the plasma concentration of the drug they have the adopted scheduled intermediate continuation, and all this cause the anti-tumor clinical effect. So the first phase 2 trial was the SWAG S04303, which includes the simple oral therapy with the capecitabine and the cyclophosphamide in the metastatic breast cancer. This is the article published in the Oncology of Breast Cancer. So the PFS, overall survival and response rate outcome with the capecitabine with cyclophosphamide was favorable in the as compared to the capecitabine alone, and the PFS, OS, and the RR with the capecitabine plus you compare with those of combination of bevacizumab, sorafenib, and hexavalent. So the recommended that the new expensive or the less convenient capecitabine combination should be tested against the another combination. And the clinical benefit rate of the women more than 65 or less than 65 was similar in this study. And the flat dosing of the oral agent was used because the clearance of the board drug is independent of the BSA. So the SWAG all oral regimen would be interested in randomized comparative effective studies to better evaluate cost, quality of life, and the preferences in the metastatic breast cancer. And it is also useful for the caregivers. So the another study which combined the 65 studies, there is a pan-European expert meeting or the PANLO project was there. They included these studies and the oral drug combination with capecitabine and the cyclophosphamide, and whenever show the additional benefit over there. There was no phase 3 study was there included in this study, and a very good toxicity profile is used. Very good toxicity profile is lost if combined with the drug and with the non-metronomic drugs. In addition, it is having a angiogenesis and immunomediated effect is also there. And the metronomic therapy was defined as a frequent, regular with a long interval. So this was the definition of the metronomic therapy that included in the PANLOP studies. Elderly derive the same benefit like younger patient, however, elderly was vulnerable. So this was the Masataka Yoshimitsu study from the Japan. They have included the metronomic oral combination of capecitabine with cyclophosphamide. In contrast to the standard low dose metronomic chemotherapy, they describe the prolonged administration of low dose of cytotoxic agent at short regular interval without extended breaks. Another, what was the method of this? The patient included a capecitabine of 828 milligram per meter square twice daily with cyclophosphamide of 33 milligram per meter square twice daily at day 1 to 114 every 3 weeks. And another study from the China, they also included the oral combination of the metronomic cyclophosphamide with capecitabine in the patient who has been treated with anthracycline and taxane pre-treated metastatic breast cancer. This is also phase 2 study. They included the oral metronomic cyclophosphamide 60 milligram per meter square daily basis from day 1 to day 14 plus capecitabine of 1000 milligram per meter square on day 1 to day 14. And the treatment was repeated every 21 days. So what was the existing data and the challenges with all these studies? There was no randomized clinical phase 3 trial was there in this. And there was no pharmacokinetic data available from the studies. There was no confirmation of the synergism. Dose used were not metronomic or used as a separate drug administration. So there was the dose was of not metronomic. It was used as a separate. The cyclophosphamide and the capecitabine used as the separate drugs, and there was a no fixed dose combination, and no systemic drug development was there due to the formulation changes. So the another Indian study from the Tata, this is a phase 2 and phase 3 trial. This is a enclosed trial. So they have included a fixed drug combination of capecitabine and cyclophosphamide that is available in the 2 different strengths. Capecitabine with cyclophosphamide at 700 plus 30 mg, and the another was capecitabine with cyclophosphamide 400 plus 20. So the study includes the dose level of 1 and 2, 3. They have included the drugs, and they included a dose 1 at the lower dose like 1400 plus 60. At the level 2, they included 1800 and plus 80. At the level 3, they included 220 and 2200 plus 100. So the morning dose and the evening dose were given. So they have taken the DC as a permission to conduct the phase 2 and 3 trial of capecitabine and cyclophosphamide in 2014. The study has, as I've said, to 2 parts. The part 1 was the randomized to receive the fixed dose combination of capecitabine and cyclophosphamide in the 3 different doses level, like group 1, group 2, and group 3. So the inclusion criteria was the female which are more than 18 years and the less than 65 years of age. And they have confirmed breast cancer, metastatic breast cancer, and they have failure to the previous anthracycline or the taxanes. And the response was measured by the RECIST criteria. The previous chemotherapy, radiotherapy should be completed 4 weeks apart from to start with the study. And what the exclusion criteria, the patient for whom hormone therapy is indicated as per the investigation discretion, patient who has taken more than one prior chemotherapy regimen for the metastatic disease, patient with known CNS lesion like brain mets or the carcinoma meningitis, and pre-existing motor sensory neurotoxicity, which having a more than grade 2. So what was the endpoint of the study? There is a proportion of the patient achieving best overall response rate, and it is made up by the RECIST 1.1, and the secondary efficacy is the proportion of the patient achieving disease control. The best overall response rate includes the CR plus PR, whereas the secondary efficacy includes the CR plus PR plus stable disease. And the safety evaluation was based on the adverse effect event. And
Sir, request you to conclude your presentation in 1 minute.
Okay, ma'am. So the patient disposition, this is the flow chart of that study, and it includes the dose level 2 and 3, and the total was 48.4, 9.29%. The BSA was on an average 1.5 in all the 3 groups. The echo performance was included in 0, 1, and 2. 3 was not, and 4 was not included in that. And the result of the intention to treat population was there. In dose 2, there was 87.04% of the better overall response rate, and in dose 3, there was 84.848. And in the PP population, it was 89.36 and 87.50% in dose 2 and dose 3. So the dose level 2 of mild, moderate, and severe was there in the including patient 86, 45, 8, and 139, and dose 3, 108, 49, and 10. So what was the most common adverse effect of the studies? Hematological anemia, leukemia, and neutropenia were common in both the group. It was more in the level 3. And the HFS syndrome was more than in the level 3, 14, that is 18.06%. Rest of the, as you noted, pain, diarrhea, constipation, vomiting was there, similar in most of the groups. So comparison was there with the earlier studies, as the phase 2 and phase 2 studies was there, as Hosmedo, Harvey, and Scottel. And the overall response rate was there. In dose 2, it was 29.62%, as in the dose 3 is 22.41%. And comparative analysis,
because we are already running short of time.
Sir, I would just complete myself. So yes, there was no randomized trial for the phase 3 of this combination. There was no pharmacokinetic data. There was no confirmation of the synergism. Dose used were not metronomic or used as a separate drug administration in the fixed drug combination. And there was no systemic drug development intent till due to the formulation challenges. So when given cyclophane, increase in the plasma concentration of the capsaicin was more with the dose proportional. And the challenges of the fixed dose combination was incompatibility between the 2 molecules, chances of impurity generation, particle size, and differential release. So this is the cartoon of the drug, and enclosed now published. This is the enclosed trial. Fixed dose combination of capsaicin and cyclophosphamide metastatic breast cancer. So what was the conclusion of the study? That the cyclophosphamide demonstrated synergistic anti-tumor activity in combination with capecitabine. Efficacy of established, it is established in metastatic breast cancer in phase 2 and 3 combination trial. Based on the CT and detailed review of comparative literature, only fixed dose combination was used, proven flat drug dosing concept, and the convenience of taking a few tablets instead of many. Thank you.
Thank you, Dr. Jitendra. So we can have the question later. Next, can I have the next speaker, Dr. Sandeep? I think Dr. Sandeep has joined. So he will be delivering a lecture on the transmission paradigm of HER2 positive breast cancer, fixed dose combination of trastuzumab plus pertuzumab, that is FESCO. Over to you, Sandeep.
So good evening, sir, and thank you for providing the opportunity on this platform of meeting on breast and lung cancer, and happy to be a part of it. So without much ado, I think I'll straight away go to my presentation. Are the slides visible?
Yes, it is. You can put in slide mode. Yes, thank you. That's good.
So I think we are really short of time. So I'll quickly go through the journey of a HER2 positive breast cancer patient. So these are the slides which have been provided by Roche. So we all know that nowadays the use of dual HER2 blockade therapy with the use of Perjeta as well as trastuzumab has been the standard of care even in the metastatic as well as the adjuvant plus neoadjuvant settings. And we have a definite data with different trials speaking for their own in terms of Neosphere trial for neoadjuvant, Affinity for adjuvant, and Cleopatra for metastatic breast cancer. So we all know that the addition of P plus H has increased the progression-free survival as well as the overall survival in metastatic cases. It has led to the improvement in reduction in the risk of recurrence or death by 28% in the adjuvant settings and neoadjuvant setting. It has led to the improvement in PathCR, from where we have evolved our strategies with the use of dual HER2 agents in these kind of patients. So these are the newly diagnosed HER2 positive early breast cancer patient, where if a patient is T1 and 0 followed by surgery, if it is node positive, we have to give pertuzumab along with trastuzumab for 18 cycles. If the tumor is more than 2 centimeters or it is node positive, then the standard therapy is use of a neoadjuvant regimen followed by surgery, followed by your decision making depending on whether PathCR is present or not. But this has been complicated with the use of intravenous pertuzumab and trastuzumab, which actually takes a long time in the clinics because these are to be administered for a longer period of time for around 1 year. So that is most important for the patient, and which actually leads to more observation time and congestion in clinics. Challenges of, we all know that the strategies are now going on from switching over to a subcutaneous regimen rather than the IV regimen, which has got similar efficacy if you see. So this has led to the evolvement of a new molecule, which is Phesgo, which is a subcutaneous preparation of pertuzumab and trastuzumab and being used in the adjuvant and neoadjuvant settings. So this has definitely reduced the infusion time, but let us discuss about whether it is really efficacious or it has got a similar efficacy in terms of PathCR or the same serum trough concentrations. So Phesgo is one of the first formulations in oncology that combines two monoclonal antibodies, pertuzumab and trastuzumab, in a single vial for subcutaneous injection. So why it is important to understand? Because it is a subcutaneous preparation, it has to be administered on thigh by using the subcutaneous route. So definitely the volume of the drug that is to be administered is more, and we need approximately a 8-minute time for a loading dose and 5-minute time for a subcutaneous dose. So the concept behind is that the drug has to be administered and dispersed appropriately in the subcutaneous tissues. So it is the presence of hyaluronidase in the drug that allows the delivery of large volume of drugs and increases its permeability to the subcutaneous tissues by depolymerizing hyaluronan. So this is we all know about the structure of subcutaneous tissue, which is actually a matrix of hyaluronan fibers and collagen fibers. So here we administer the recombinant hyaluronidase to make the drug more and more dispersible, and the availability of make the availability of pertuzumab and trastuzumab accordingly. So after the subcutaneous administration, the architecture of skin is again reformed within 1 or 2 days, and because there is a fast hyaluronan turnover. So this is the administration immediately after post-infusion when we have not used hyaluronidase, and this is after the administration where you can see that the bleb is actually not formed if we have correctly administered the drug in a proper formulation. So now we come on to our first point, that whether these kind of drugs have the similar pharmacokinetics, efficacy, and safety. So this was one of the first phase studies, that 30185, which actually confirmed that the dosing is appropriate, loading dose of 1200 and then 600. So the loading dose is 1200, 600, maintenance doses again 600 pertuzumab and 600 for trastuzumab. So again, after that, we had a concluding Frederica study that we'll be seeing in the coming slides. So this was the overall complex design of the study, which led us to believe that the loading dose is 1200 milligram. A maintenance dose of around 600 milligram is required to be used in a formulation like Phase-Go, because it actually administers the drug in a right concentration, which you can see is pharmacokinetically equivalent to the IV preparation. So this was the Frederica study design, where after the use of anthracyclines, AC regimen, followed by the taxane combined with dual HER2 therapy, whether it is given by IV route or the subcutaneous route. So let us come to our primary endpoint, which was the trough concentrations at the cycle 7, that is pre-dose 8. So this clearly demonstrated, you can see here, the trough concentration, plasma to serum concentrations measured at the end of dosing interval was clearly better if you see in terms of subcutaneous administration. So the primary endpoint and the secondary endpoint clearly led to that the gross mean margin is exceeded, which was actually 0.8, which was exceeded, and so the primary concentration of the trough levels were almost equivalent. In terms of efficacy, the PATH-CR rates were almost very similar. If you see, around 60% of the PATH-CR rates were seen in the ITT population, and it was not and they did not differ with the use of body mass index. Even if the weight was low or the patients were overweight, the results did not differ. So adverse effects were almost similar between the two arms. They did not have any safety concerns. So again, our main concern was whether it led to any worsening of the cardiac dysfunction, which we are actually worried of, or any hypersensitivity reaction. So there were no alarming signals that were seen at the end of trial. So again, no meaningful differences in the cardiac safety were seen. So yes, Phase-Go is actually non-inferior if you consider the primary serum trough concentrations. PATH-CR rates are almost equal. Safety results are very similar. No new alarming signals. So yes, it is a very effective drug with a less infusion time and can be actually taken into practice, clinical practice. So do the patients prefer the subcutaneous preparation or an IV preparation? So this was again a PH-RANS Phase 2 data determining that majority of the patients will be seeing here that this was a crossover period after 3 cycles of IV followed by subcute, and then subcute followed by IV. So majority of the patient, the preference, around 93% of strong belief or inclination towards using a subcutaneous regimen compared to the IV regimen, because it is more comfortable and provides less time to the clinic. So a majority of the patients, you can say, switched over, or they used preferred subcutaneous regimen over the IV preparation. They had, in fact, more time to speak to their healthcare practitioner over their other issues rather than wasting their time on the subcutaneous IV preparation. So this we have already know that IV takes a long time, subcutaneous takes less time, but yes, to an extent, adopting it into in Indian practice would take some time, because we need to train our nursing staff as well as the doctors in administering the drug, because 8-minute subcutaneous preparation is actually not an easy job. So again, adverse effects in this trial, they were also very similar. Again, we had no concerns regarding the alarming signals regarding the use of this preparation in terms of side effect profile. So there are certain tips to administer it very comfortably. You should administer on a thigh, right thigh or left thigh. Again, never administer on an abdomen. Again, don't divide the syringes. Always administer the area not at the previous site. Don't use a site which is actually bruised or tattooed. So these are some of the precautions that healthcare practitioner or nurses need to actually look at. So observation time is almost half an hour after administering the drug to look for any anaphylaxis or skin-related reactions. So again, what could Phase-Go mean for patients as well as HCPs? Patients, in term, if you see, it actually improves their comfort, their likelihood of having less side effects and less time in the clinics. For healthcare professionals, again, the ease of administration, shorter duration of time, and if you see the efficacy, it is almost going to be the same. So yes, it could be a game changer in our clinical practice. So Phase-Go is one of the first formulation in oncology to combine 2 mAbs P plus H in one subcutaneous injection, and offers a faster and less invasive route of administration. Our concern was whether it is efficacious or not. The trough levels clearly demonstrated the drug concentration is not going to change. PCR rates, again, in terms of clinical practice, you see PCR as a gold standard of measurement of efficacy of a drug. They were very, very similar. Majority of the patients, 85% preferring Phesgo, always speaks about itself that patients need to visit the hospital, spend less time in the hospital, which actually speaks volumes about this drug again. Majority of the healthcare practitioners prefer switching from an IV to subcutaneous regimen, and it is now FDA and EMA approved for the same indications. So thank you all for having me here, and I'll be happy if there are any questions at the end of the session.
Thanks, Sandeep. So Phesgo is a talk of town right now. So everybody is having a discussion again. We had just had a chat with the Dr. Kunal in chat box. So can I have next speaker? We can have a question a little later. So because we are already late. So Nadeem, are you there?
Yes. Yes.
So Dr. Nadeem will be taking the next session. So discussing the overall survival of Paloma 2 trial. So over to you, Nadeem.
How can I share my screen? Because I'm not able. Okay, now. I hope my slides are visible.
Yes, it's there.
Okay. So I will be talking regarding the overall survival data of this Paloma 2 trial. So starting with the, basic landscape, as we are well aware how hormone receptor-positive HER2-negative advanced breast cancer has evolved over a period of time, starting since 1980s. It was a tamoxifen, and then following that came anastrozole, letrozole, then exemestane, and fulvestrant. But if we carefully look at those drugs, time to progression was with tamoxifen most of the time it was less than 9 months, while non-steroidal aromatase it was less than 12 months, while fulvestrant it was just less than 6 months. Then came the palbociclib. It was the first in-class CDK4/6 inhibitor. It was a orally active selective inhibitor of CDK4/6, and it inhibits cell proliferation and cellular DNA synthesis by preventing a cell cycle progression from G1 to S phase. So this was the Paloma 1 data. It was a phase 2 study. In this, they combined this palbociclib with letrozole, and another arm, it was letrozole alone. So as you can see that there was a remarkable difference in terms of a BFS. It was almost double as compared to the letrozole alone. So looking at this this chart, this cartoon, as you can see, now there was a remarkable breakthrough in the form of a CDK4/6 that has come up in the 2015. So with this background, Paloma 2 trial was carried out, and for this FDA approved accelerated approval, and so it was again a randomized double-blind phase 3 study, and in this, in one of the arm they gave letrozole, another arm they letrozole plus placebo, another arm was palbociclib plus letrozole. So similar was the findings what it was in the Paloma 1 trial, like PFS was 24.8 months with the combination therapy, while it was 14.5 months with the placebo plus letrozole arm. So if we look at the baseline characteristics, it were almost same, and in fact there were patients which were those who were having even a visceral disease, they were also taken. Well, one thing is to be, remember that it's not something who is having this visceral disease, he doesn't qualify for CDK4. So it is just the burden of a disease which is really important. Somebody who has got there are visceral mets, but the burden of disease is not that much that it produces organ dysfunction or it is impending organ dysfunction. Still, you can consider for CDK4/6 inhibitors to be used. So this was the investigator assessed PFS, as I previously pointed out that it was almost double as compared to the combination, this monotherapy arm of letrozole, that is 27.6 months versus 14.5 months. And moreover, time from randomization to the first chemotherapy, again, there was a 10.5 months delay in the chemotherapy if we use the CDK4/6 along with the letrozole. So, and whatever pre-existing musculoskeletal disorders are those who are having GI disorders, everywhere it was found to be beneficial. So looking at subgroup analysis, no matter what subgroup you take, everywhere it combination of a palbociclib plus letrozole has scored over the placebo letrozole. And now coming on to the this other CDK4/6 inhibitors. If you carefully look at the other CDK4/6 like ribociclib, abemaciclib, everywhere you just note down that the hazard ratio has been most of the time same, somewhere around 0.4, 0.5, 0.4, 0.5. So we can confidently say that almost all of those CDK4/6 inhibitors are equally beneficial when we use it in a first line setting. So there is a ASCO update, this from Paloma to ASCO 2022 update. What they gave this OS analysis after required events were reached in November 2021 with a median follow-up of 90 months. So if you see the intention to treat population, there was not much of a difference in the OS. I mean, rather no difference. But then there was a reason behind that. The reason behind that was that there was a disproportionate loss to follow-up and missing survival data was seen between the treatment arm, with a larger proportion of patients who were unavailable in the placebo arm. And moreover, those patients who were missing, they were mostly labeled as alive at the last contact. So this can be the sole reason why there has not been the much difference. And moreover, if you carefully look at the trials, this was the only Paloma series trial where they have taken even those patients who are endocrine resistant. I mean, in other of the trials, there are none of where they took endocrine resistant. In those trials, they took endocrine resistant also. So looking at those who are endocrine sensitive, that means those who had a DFI of more than 12 months, there was a median OS was remarkably different with the palbociclib plus letrozole as compared to the control arm. But then after looking all those trials, I mean, yes, trials are definitely important in guiding us the treatment decision. But then important remains the real world evidence also, because real world evidence tells us the exact picture of a community. I mean, how do breast cancer behave in a community and how do they respond to the treatment? So yes, there is a publication of this real world evidence regarding this use of a palbociclib from the US. There is a Flateron US data. So what they found that median OS was with a combination therapy was not reached, while with a letrozole it was 40.3 months, and it was similar whether you take unadjusted analysis or a propensity score matching. In both of the analysis, you can see that median OS was not even reached in palbociclib plus letrozole as compared to the letrozole alone. As far as safety is concerned, although I mean, after looking at this, we may get a bit frightened that there are most of the time grade 3, grade 4 adverse events we get to see with the palbociclib. But to be very honest, the only grade 3, grade 4 adverse event was that of a neutropenia. But surprisingly, none of those neutropenia turned out to be this life-threatening febrile neutropenia. So it was just a lab reporting rather than a clinical reporting. But if we look at the other CDK4/6 inhibitors like ribociclib or abemaciclib, there were other toxicities also in the form of a GI disturbances or a liver dysfunction and then cardiac disturbances. So looking at the monitoring, I mean, how we are supposed to monitor all those the use of those CDK4/6 inhibitors with this palbociclib, we are supposed to monitor just CBC and especially in starting 2 cycles, we look for a day 1, day 14, but after that we are supposed to see it check it just once before the start. And while with the ribociclib and abemaciclib, we are supposed to monitor the other lab parameters also in the form of like ECG, serum electrolytes, and LFTs also. So in summary, we can say that all CDK4/6 inhibitors are similar in terms of efficacy and but there can be difference in the terms of a safety profile as well as quality of life. And moreover, in present NCCN and ESMO guideline, they do recommend that the standard of care as a first line in metastatic breast cancer usage of a CDK4/6 inhibitors plus endocrine treatment. And yes, PFS remains the gold standard in the tumor with a longer post-progression survival. And moreover, the interpretation of a OS in Paloma 2, there is a limited in the form of a like there was a missing survival data and there was a different patient population. And moreover, there were inconstant treatment effect throughout the observation period. So yes, we can say that a toxicity profile is a bit different in all those CDK4/6 inhibitors, and yes, there are consistent differences. And overall, we can remember that this usage of a palbociclib and ribociclib, they present more with a bone marrow toxicity, while with abemaciclib, it has been seen to produce more of a GI symptom and less pronounced hematologic toxicity. So with this, I mean, background, we can even select the CDK4/6 inhibitor for the patient. I mean, somebody who has already got the low counts or who has got a comorbidity in the form of a, like say MDS or some other hematological problem. In that case, we will try to avoid this, especially palbociclib and then ribociclib. We will try to use this abemaciclib. But otherwise, I mean, in other of the patient population, you can consider use of this palbociclib as well as ribociclib. So with this, I end up my presentation. Thank you.
Thank you, Dr. Nri. So, Dr. Anubha, can I have one quick input to this talk from your side? I think so. We should. Dr. Anubha is not there. So, just to say that it is still the drug which we have more experience. So, it's the first drug to come up, and that's what the topic. It's deciphering the Paloma 2 trial. Because of the missing data, we were not able to say whether that overall survival benefit is able, we can predict or not from there. So next talk is from my senior Dr. Kunal. So sir is my senior in DMC UAE Ludhiana. So sir will be giving a lecture on getting real with the ribocycline. Over to you, sir.
Thank you, Dr. Jagdeep. Good evening, everyone. And thanks once again for organizing this meeting and including us to be a part of this meeting. And I have, I think, 5 or 7 minutes for my scheduled closure time. So I'll try to run through this presentation quickly. So
no, don't restrict so much, sir.
That's okay.
So we did not want to squeeze everything on
No, that's fine. So I think a lot of things about CDK4/6 inhibitors we have already heard in the previous talk, and it seems to be like a debate. Dr. Nadeem already spoke very well on what the palbociclib data is in MBC. So what I am going to do is present the slides which have been sent by Novartis, and seeing and just only a very minor changes, and seeing what is the real world evidence with the ribociclib and whether it matches what we see in the randomized control trials, because that is always the fear that we have, because that is a very controlled set of population in trials with very good performance status, all good lab parameters, and that is not what we see in our real world practice. So whether that will hold good, the same strategy or not, that is what we are going to see in the next few slides. So these are the two terms which have been listed in the ABC5 guidelines, and may be important to remember, like we do for other tumors like ovarian tumors. So what is primary endocrine resistant and secondary endocrine resistant, because a lot of trials will have varying populations of patients involved, and that might also be impacting on the results. And I think the gold standard definitely from the patient's point of view is always overall survival. Everyone wants to live as long as possible, and that is our goal as well. But I do agree that majority of the trials or the data is dependent on PFS, and especially in studies of diseases where survival is relatively longer, like breast cancer. Now we are looking at survival on an average of about 5 years in breast cancer, hormone positive, even in HER2 positive, close to 5-year mark we are having with all the modalities that we have at our disposal. So that is the gold standard, overall survival. So now how to choose which molecule to choose. It is, I think, kind of a similar story that we have in the cricket team. Now we know that CDK4/6 inhibitor is a vital or kind of essential in the real world. If there is no restriction, every patient with advanced breast cancer, hormone positive, HER2 negative, will get a CDK4/6 inhibitor in combination with another hormonal agent. So it is like a wicket keeper, which is essential part of the team anyway. So which one do you choose among the 3 that we have now available? There are others also, but at least the 3 that we have available in the market among the CDK4/6 inhibitors, which one do you choose? So ribociclib basically scores on the major front in terms of standing the test of time and proving to be of benefit, having benefit in overall survival. In all the 3 studies, in Mona Lisa 2, 3, and 7, in postmenopausal as well as in pre and perimenopausal Mona Lisa 7, it has shown that it achieved overall survival. Abemaciclib also did in its trial in Monarch 2, but the palbociclib studies did not meet that endpoint. So I added this slide just to show that the PFS benefit, if you see across the studies among various CDK4 inhibitors, it is kind of similar, just above 2-year range mark. So 27, 25, 28, roughly that range. Mona Lisa 3 with fulvestrant is kind of an exception with the PFS of 33 months. And if you see the response rates, they are also kind of similar across the trial. So there is a lot of variation possibly in the patient population also, which may be driving the different results. And among the ribociclib trials, all 3 trials, the survival is close to 5 years in all of them, and maximum in Mona Lisa 3 with about 67 months of overall survival. So the first study with the there are 2 studies, the complement 1 and the Ribana, which is the German study, and we'll go through these studies one by one. Complement basically enrolled close to 3,200 patients with no prior endocrine therapy for advanced breast cancer, and no prior chemotherapy or less than 1 line of chemotherapy. And ECOG performance status 2 was also included. So that is something that we will see in our clinics also. But in trials, only 0 or 1 are included. And also CNS mets were permitted. Almost 51 patients had CNS mets, which was exclusion criteria in most of the studies. And in this study, which was basically on ribociclib and letrozole, the primary endpoint was safety and tolerability, and other things like time to progression, overall response rate, benefit rate, and patient-reported outcomes were secondary endpoints. The Ribana, the German study, is enrolled. It has enrolled about 2,600 patients, and basically 3 sets of treatment arms that the patients were put in, not a randomized manner, but it's a real-world setting. Patients would either get endocrine therapy alone, which used to be our go-to strategy maybe 5 or 10 years back, and some of them will get chemotherapy, especially those who have visceral crisis. And now majority we will be offering ribociclib with the hormonal therapy. So the first study, the complement 1, where 3,200 patients were studied. So you can see there are some patients which would otherwise be excluded from the trial, like patients with CNS mets, 51 patients, relatively not that good, borderline performance status of 212 patients. Patients with visceral mets were close to 2,000, and prior chemotherapy were about close to 200 patients. So all these kind of are relatively poorer risk group, which will do poorly anyway, because we are giving chemotherapy to a patient because the patient is already in a bad shape, bad stage, and is in visceral crisis. And the adverse events that were reported in this study, mainly it is the neutropenia, which was consistent with what we would see in our which we would see in the previous studies. And the way they reported it was in patient adjusted years and number of episodes that were there, and they were studied over the course of treatment of the patients, and the majority of the neutropenia episodes were seen during the first year or so, and gradually the number of neutropenia episodes declined. Other problems like OTPT elevation and QTC prolongation was there, but not very significant, but it mandates that we monitor the LFTs and ECG at least during the first 2 months of therapy. I had a patient who had significant elevation of transaminases. Re-challenge with the lower dose, only 200 milligram, again led to similar rise in transaminitis to about 1,000, which was about 15 to 20 times, and which normalized within a couple of weeks after stopping ribociclib, and that patient was doing well on palbociclib. So that is something we have to be careful about. And what we saw in terms of time to progression, I showed the initial data, which was just in excess of 2 years. And here also the time to progression was just above 2 years, 27 months. And under exploratory analysis, median PFS reported was 26.7. And patients with measurable disease, obviously the response rates would be higher because you are able to measure. I don't think we can carry much from this slide, but anybody who has a measurable disease, you will be able to assess the response much better in that. Otherwise, patients only with bony mets may only be judged as having stable disease. Now, coming to the other parameter of CNS mets, as I mentioned, most of the trials will exclude these patients, and only about 15 patients across 3 trials were included who had stable CNS mets. But in this complement study, which included about 51 patients, the median PFS was still not reached in that subgroup of population. Again, it is a small subgroup, but again showing that this strategy may be a valid strategy for patients even with the CNS mets. And whether patients had prior chemo, poor performance status, visceral mets in combination with prior chemo, and visceral mets and poor, relatively poorer performance status, there was some amount of benefit seen with adding CDK4/6 inhibitors. And patient-reported quality of life measures were kind of all in favor of using. There was not much of decrement in using this molecule. And coming to the second study, Ribana, where the 3 arms, as I said, chemotherapy, only endocrine therapy, and majority of them, among the 2,600, majority of them did get ribociclib either in combination with fulvestrant or AI. It showed, again, an impressive median PFS of about 37 months, much higher than what was previously seen in the studies. And even the endocrine therapy arm did much better in terms of 26 months of PFS. And chemotherapy arm showed a PFS of 15 months. So all the arms are doing better. In fact, if you see the previous studies, the chemotherapy arm only has a PFS of about a year or so. So 14 months or so. And safety-wise, the study showed that the safety signals were similar to that were seen in Mona Lisa studies. And most common adverse events were neutropenia in 1/4 of patients, nausea and fatigue, again in 20 to 25% of patients. But majority of these are kind of not dose limiting. We know that up to 1,000 ANC, we don't need to reduce the dose, but once the counts ANC is below 1,000, we need to go down to the next dose level. Or if the patient has neutropenic fever, we need to stop temporarily and wait for recovery and then go to the next dose level. So this is showing the data of the ribociclib in trials, Mona Lisa, all 3 trials, and also in the real world setting. We can see kind of the median PFS is similar, and in fact, Ribana is showing higher PFS as was seen in the studies. But again, this is not a randomized or a strictly controlled subset, but at least reassuring that what is shown in the studies can be obtained in a real world setting also. And dose reduction is something that we also have to be careful about. Nearly half of the patients, or at least 1/3 of patients in the 2 trials, 3 and 7, and half in Mona Lisa 2, did have some amount of dose reduction due to adverse events, and majority is due to neutropenia. And 1/3 in Ribana also underwent dose reduction. So based on the data shown by Dr. Nadeem and also the Mona Lisa studies, now the current standard of care in patients with endocrine receptor positive advanced breast cancer, the first line of therapy is hormonal therapy with a CDK4/6 inhibitor. Which one you choose? Again, I think palbociclib was the one which was earlier only available, but now with ribociclib showing overall survival benefit data, it is kind of overtaking palbociclib and abemaciclib. We are more fearful of impaired quality of life and more side effects. And there is something called as magnitude of clinical benefit scale, which is done by ESMO, and ribociclib scored well across the trials, and score of 4 or 5 is needed for approval. So are these drugs different? Possibly a bit of different in the lab. Palbociclib is kind of equipotent for CDK4 and 6. CDK4 receptors are more on the breast tissue and 6 more on bone marrow cells. And ribociclib has more preferential activity for CDK4 than 6, whereas abemaciclib, again, it is kind of not only CDK4/6, but labeled as CDK4, 6, and 9 and has a lot of off-target kinases which are inhibited, and that is why there are a lot of side effects or GI toxicities which are related with the mibaciclib. I don't think that is relevant. So in summary, outcomes from randomized control trials can be replicated in real-world experiments shown by these two studies, Complement and Ribana. And most of the guidelines would recommend early usage of CDK4/6 inhibitors for patients with HR positive, HER2 negative advanced breast cancer. And ribociclib has shown the longest and most meaningful OS of close to 64 months from Mona Lisa 2, and in Mona Lisa 3, in fact, 67 months. And it is across the trials, OS survival advantage has been shown. And as I said, the ESMO MCBS score of 4 to 5, which led to its approval there also. And it demonstrates similar efficacy and safety in close to 6,000 patients that were studied in both these studies. And in terms of efficacy, it also showed in patients who had CNS mets, visceral mets, and chemo-related, previously treated with chemotherapy and ECOG performance status of 2 or more. And there may be some differences in CDK4/6 inhibitors, more so in terms of toxicity. And I think it will depend mainly on which molecule will have its next first generic, which will come, and that possibly will determine how we are going to use or in terms of bulk usage. With that, I will end, and I'll also invite all of you to our upcoming meeting on 12th and 13th of November in Ludhiana. That will be not a virtual meeting, in-person meeting. So we'll soon send the flyers for that. So with that, I'll end. Thank you.
Thank you, Kunal sir. And your ending is very great. And thanks. And the most important thing in this that sir has already invited all the faculty respected by seniors for our cancer conclave, which will be going to held on 12th and 13th of November. So thank you, sir. So next session is by Dr. Burhan. So he will be speaking on the rucaparib in ovarian cancer. Dr. Burhan, are you there?
Yeah, good evening, Dr. Jagdeep.
So Dr. Burhan, he is a medical oncologist at AOI Jalandhar. So over to you, Dr. Burhan.
Thank you, dear. Just I will share my slides. So at the outset, I would like to really compliment Dr. Jagdeep and all the team that has put a lot of effort in getting this CME arranged today and getting all the medical oncologists from the North India connected and talking on a very important topics, lung, the breast, the ovary. And the topic that will be talking today, it will be on the role of rucaparib in the ovarian cancer as a first-line maintenance therapy. So to begin with, I would like to say that this is what we have, the typical course of advanced ovarian cancer in our day-to-day practice. We see that majority of the patients, close to around 70 to 80% of patients, they come in stage 3, stage 4 disease. And these patients, they are being subjected to the surgery, either primary or interval debulking surgery with either a neoadjuvant or adjuvant chemotherapy with with or without anti-VEGF therapy. And majority of the patients do achieve the first responses, and these patients are put on the follow-up. But the problem with the ovarian cancer is that almost 70 to 80% of patients, they have a progression, and this progression, it depends, it is in turn depend upon what is the platinum-free interval of these patients, how they are going to behave, and what is the second line of treatment that we're going to choose in these patients. Fortunately, we have some treatment options as a second line, and they achieve the response. But after some time, these patients, they develop refractory disease, and this in turn leads to progression, and they succumb because of the disease. So this is the usual course what we have in advanced ovarian cancer. And this course has been replicated in many of the ovarian trials that were done by the AGO group. And it was found that what we have in the, if we see this curve, what we see in this curve, that how the patients are going to behave. And the median PFS of these patients has been seen to close to around 18 months. And the PFS for 5-year PFS is around 22%. So this means that majority of the patients, they are going to have the relapse within, you can say that within the first 2 years after the diagnosis of the ovarian cancer. And this is how actually we see the ovarian cancer, as far as if we actually measure the CA-125 levels at the outset, at the time of diagnosis. If the levels are high, once we actually give them the treatment, the surgery with chemotherapy, with or without anti-VEGF therapy, they respond. There is a plateau on these. Then there slowly the symptoms come up, or there is an increase in the CA-125 levels. We go the second line. Then again, second line treatment, it leads to a fall in these levels and some response. Then again, there is a increase, and this happens over a period of time. And subsequently, what we have, the fourth line or fifth line, if the patient goes, ultimately they become refractory to the lines of treatment what we have, and ultimately the majority of the patient is come because of the disease. So what we have understood till now with all the studies, that there is definitely an unmet need for the patients with ovarian cancer. And the need is in terms of improving their quality of life, the PFS, the time to first subsequent therapy, the OS, and the cure rates. And this need is for additional safe and effective maintenance options. So we need not actually just put those patients on, you can say, the follow-up, but we need some sort of treatment so that these patients we can delay their progression and in turn improve their survival as well. So what we have to understand, that the epithelial ovarian cancers, they are not a single disease. And we have a spectrum as far as their morphology is concerned, in the histological parameters or in terms of the genetic profiling of these epithelial tumors. And yet majority of these patients are being offered what we conventionally have, the paclitaxel and the carboplatin, the doublet based chemotherapy that's being offered. Now what has happened, that since 2003, there has been a lot of studies as far as how to actually improve the PFS and the OS in these patients, and a lot of maintenance studies, trials were conducted. The initial trial, they tried to use the role of chemotherapy, tried to see the paclitaxel, where we had the GOG 178 trial, which showed there was some benefit in the PFS, but it had its own disadvantages. Then we came the role of, the role of anti-VEGF therapies, the bevacizumab in the first line maintenance therapy. And slowly, I think somewhere in 2012, then there came a role of the PARP inhibitors, especially in patients who have BRCA mutant, And slowly from 2017 onwards, we saw these all these PARP inhibitors as a maintenance in second line and beyond. But from 2018 and 19 onwards, and now in 2022, with the role of these PARP inhibitors in the first line maintenance has come up. And especially what I will be talking today about the rucaparib, what we have the first line maintenance based on the ATHENA-MONO trial. So this ATHENA-MONO trial, it was a phase 3 double-blind randomized trial. And they were the patients that were enrolled, they were stage 3, stage 4 high-grade epithelial ovarian cancers who had underwent complete cytoreductive surgery, who had underwent 4 to 8 cycles of doublet platinum, doublet chemotherapy. And these patients, as of now, there are 4 arms that are being tested. And the arm A, it includes the rucaparib with the nivolumab. Arm B is rucaparib placebo, arm C is placebo with nivolumab, and the arm D. So what the ATHENA-MONO, the study results that are currently available, it is about the arm B versus the arm D. So it is the rucaparib versus the placebo. And the primary endpoints that were studied, they were the PFS, and the secondary endpoints were the OS, overall survival, and the safety profile of these of the drug. So this is about the Ethnomona study, if we see they were assessed, though a lot of subset analysis was done. The first subset analysis, it was about the HRD population. So if we have a homologous recombination defect, so how these patients are going to behave. So it was found that there was a significant improvement in the PFS. So rucaparib arm, it was 28.7 months versus placebo 11.3. So there was a hazard ratio of 0.47. So there was a significantly prolonged improvement in PFS. And this was the more remarkable about the intent to treat population. So all the patients that were enrolled, so how they fared, we see that the two arms are widely apart, and the rucaparib, the median PFS were 20.2 months, the placebo was around 9.2. So again, there was a benefit as far as the PFS was concerned. And this was about all the patients, so whether they were HRD positive, HRD negative, or how they behaved. So if we see in all the subset populations, there was a difference and there was a separation of the curves. And this is about, again, the various population that was subgroup population that I was talking. Intent to treat population, definitely it benefited all of them. If we see the based on the HRD testing, again, whether they were HRD positive or HRD negative, they still had the response. And if we see the stage of the disease, the performance, the timing of the surgery, and the CA125 levels, all of them had a response. So all of this favored the rucaparib. So coming to the safety and tolerability of the rucaparib, so we can see that definitely there was more of grade 3 treatment related adverse effects with the rucaparib. But if we see the discontinuation rates, they were not very high. It was 11.8% with the rucaparib, was 5.5 with the placebo. So definitely there were some of the toxicities and that were seen with the rucaparib, but majority of them were grade 1 and grade 2. This is the various toxicity profiles that were encountered with the rucaparib versus the placebo. There were toxicities, but majority of the toxicities, I can say, they were low grade and they were tolerable. If we see the grade 3 toxicity that were more seen with the rucaparib, it was the anemia levels that were seen. The grade 3 was close to around 30%. Then there was an increase in as far as the liver enzymes that was seen, the neutropenias that were seen. They were high.
I would request you to conclude your presentation in 2 minutes.
So what you can see with the conclusion of the trial was that the first line maintenance therapy, it improved the PFS as compared to placebo in all the patients who were diagnosed with advanced ovarian cancer, and the benefit was regardless of the HRD status. And there were no safety signals that were observed with the rucaparib, and this led to the conclusion that first-line maintenance therapy with rucaparib, it imparts a significant benefit in ovarian cancer regardless of the HRD status. So this is actually the final the slide that we see that currently we have number of options as far as the first-line treatment option for ovarian cancer is concerned. And if we see the rucaparib with the availability of the Ethnomona trial, this has shown a benefit across the subgroups that was not seen as far as the other PARP inhibitors or the available or the role of the anti-VEGF therapies was concerned. So with this, I will conclude the talk. If there are any questions, I will be happy to have them. Thank you.
Thank you, Burhan. So we'll take the questions at the last. Next session is by Dr. Sumit Goyal. So sir is Associate Director in Rajiv Gandhi Cancer Institute in Medical Oncology and presently heading the team who treating the ovarian cancer. And the most important thing, he is the person who guided me, or who showed me that for the medical oncology profession to go in that side. So, sir is there?
Dr. Jagdeep, thank you very much for the kind introduction. And thanks for the praise you have showered me. It is your hard work.
You are my elder brother, sir. That's why, because you are the person who made me to go to that side, that you have to work for this.
So you are going to blame me in the future for doing politics.
No, sir. So over to you, sir.
Okay. Thank you, Dr. Jagdeep. Thanks, organizers, for giving me this opportunity here. So my job has been done very easy by Dr. Burhan Wani. He has set the pitch for me right. So moving on, I think I'm audible and my slides are visible. So
Yes, sir.
I will be talking on basically recent trends in the management of ovarian cancer. So basically, the slides have been taken from various websites which are open source and for the educational purposes. So in 2022, so there were many gynecological conferences. The crux of the story for the ovarian cancer, we know in the past 2 decades, we had either paclitaxel carboplatin plus minus bevacizumab in the first line. And addition of bevacizumab, we also know that did not improve the overall survival. So there was definitely an unmet need, which Dr. Burhan Wani elucidated too. So there was the new kids on the block in 2005, that was the PARP inhibitors, which was olaparib. So the journey which PARP inhibitors have made in this era is commendable. So we now have something to deal with which we never had earlier. So just give me 1 minute. So it has opened. So if we look at how we make our diagnosis, basically there are 3 decision-making points which we need to remember. And so important one is, we know first we need whether we are giving the patient is going for neoadjuvant chemotherapy or it's going for interval cytoreduction. Then second decision is whether to add bevacizumab and when to add. The third thing is the maintenance. Here, Dr. Burhan elucidated to the rucaparib, which is coming up and is there. So recently, so moving on, we will skip this, how PARP inhibitors work, and we'll come to this. So basically, we know about 50% of the patients with high-grade serous epithelial ovarian cancer, they are HRD. And BRCA1 and BRCA2 mutations are the most common mutations. They constitute approximately 16% have germline BRCA mutations and 4 to 7% have somatic BRCA mutation. And in our testing, we know that routinely we are sending patients for BRCA testing nowadays, and it is essential. We know PARP inhibitors have clinical activity beyond BRCA mutated ovarian cancer also. So altogether, BRCA 8 and 6%, BRCA1, BRCA2, germline and somatic constitutes approximately 20% of the patients. So this is a journey how the PARP inhibitors have been approved by the FDA and has been closely followed by the ESMO also, by the European medical agencies also. So there is enough data, as said by Dr. Burhan also, about the PARP inhibitors in the maintenance therapy and the recurrent ovarian cancer. So this year, the talked about studies were 3, SOLO-1, PAULA-1, and PRIMA. I will be just presenting the updated data from SOLO-1 and PAULA-1. So this year, the 7-year follow-up was presented at ESMO 2022 annual conference in the newly diagnosed advanced ovarian cancer patient with BRCA mutation who had received maintenance olaparib. So in the background, we know ovarian cancer patients, they have poor overall survival rate, close to 17% at 10 years. So we know once the ovarian cancers relapse, they are typically incurable. So there is definitely unmet need. So the results from SOLO-1 trial demonstrated the efficacy at 2 years of maintenance olaparib in women who were newly diagnosed and had BRCA1 and BRCA2 mutations. So at 5 years of follow-up, approximately 48.3% and 20.5% were progression-free in the olaparib and the placebo arms respectively. And here they had presented 7-year follow-up also. This was the study, the patients stage 3-4 who high-grade serous or endometrioidal who had BRCA mutation and had responded to either were in CR or PR after platinum-based therapy were randomized to receive OLA or placebo. And here in the primary and updated analysis, they showed, the investigators showed the primary analysis, PFS was not reached with the olaparib arm, versus it was 13.8 months with the placebo with significant p-value. And in updated analysis, at 7 years, it has increased to 56 months, which is really something commendable as compared to the placebo, which is the same 13.8 months. So the aim was to assess the long-term efficacy tolerability of 2 years follow-up. So all the characteristics were well balanced. We'll skip this slide. If we look at the follow-up OS. So if we look at the numbers, so in the olaparib arm, it was not reached, whereas in the placebo, it was 75.2 months, which looks very impressive again in the placebo arm also with a significant p-value. But here the point to remember is that we will come in the subsequent slides also. So here the subsequently also the patients who were in the placebo arm, they had received PARP inhibitors. So probably that has placed the increase in OS here. But if we look at the 7-year follow-up from time from randomization to the first subsequent therapy, in the placebo arm, the subsequent therapy, they started just in 15.1 months. Whereas in the olaparib arm, it was still 64 months. They were still continuing. So which is really very good. And it was maintained at 7 years also. And if we look at the second subsequent therapy, which was again very good. In the placebo arm, it was 40.7 months compared to olaparib 93.2 months. So safety, again, there were no new safety signals. It was the same. The majority that we worry about was the MDS, but it did not differ much at 7 years also. And pneumonitis and all were the same which had happened initially. So same thing again. So the investigators concluded from this study was that there was clinically meaningful but not statistically significant improvement in OS with maintenance olaparib as placebo. One of the reason was the crossover. The hazard ratio was 0.55, and patients who had received olaparib, 67%, 2/3 of patients were still alive who had taken olaparib maintenance at 7 years. So the benefit was observed despite 40% of patients crossing over and subsequently receiving the PARP inhibitors. And again, they had subsequent therapies to first and second line. They were still in favor of olaparib. As I said earlier, no new safety signals were observed. So the other study was PAULA-1, which was phase 3 study. It was in combination with bevacizumab. So let us see what the updated 5-year results showed this. So we know the same subset of patients, the significant PFS benefit was observed in OLA plus BEV as compared to the placebo plus BEV arm. The overall hazard ratio was 0.59. So this was the study about the same thing. The patient who had received PR and CR, they were randomized to receive olaparib plus bevacizumab or to continue placebo plus bevacizumab. Here, at least they should have received minimum 3 cycles of bevacizumab in this study. The primary endpoint was PFS and the secondary was PFS2 and OS. So again, well-balanced study in terms of various characteristics. So if we look at the intent to treat population, again, the curve seems to be merging, not much difference, just numerical differences, p-value not significant. But again, this is at 55% maturity. And again, the major why it was so was because the patients had received PARP inhibitors during any subsequent therapy. So, but if we look at the HRD positive group, there is some differences in the olaparib plus BEV versus placebo plus BEV group. So subsequently, also the patients who were in the placebo arm, so 50.8%, 50% or more patients still receive olaparib on progression. But if we look at here, numerically significant OS survival benefit, 65.5 versus 48.4%, which is quite impressive. And if we look at the PFS, which was the primary endpoint of the study, they have shown hazard ratio of 0.41 in favor of the OLA-BEV group. 5-year PFS was almost more than double, 2.5 times as compared to the placebo BEV arm. So nicely separating curves at initiation and still maintaining. So OS by HRD status, subset analysis, if we see that. So 5-year OS was 73.2 months versus 53.8. Again, the 44% of patients had received olaparib in the subsequent therapy lines. And same here in the HRD positive, excluding BRCA mutations. And Dr. Burhan Wani had shown in his slides the schema, how the BRCA and non-BRCA genes are there, the BRCA. So it was there, still the benefit was there, the BRCA-ness we call it, but in the HRD negative group, the curves were numerically better, but not quite significant here. So again, adverse events of special interest, they were similar, no new safety signals. So the investigators' conclusions were there was meaningful OS benefit observed in HRD positive patients who were newly diagnosed, and the 5-year OS rates was 65.45% versus 48.4%, hazard ratio of 0.62. This was observed even when 50% of patients in the control arm, they received the PARP inhibitors post-progression. And they observed that the benefit was there regardless of the BRCA mutation status. The similar OS benefit trend was observed in the HRD negative subgroup also, and no new safety signals were there. So the investigators, they feel that the data support addition of olaparib to bevacizumab as standard of care for HRD positive patients with newly diagnosed advanced ovarian cancer. And they say that we need to confirm and optimize based upon the biomarker testing. So in NCCN, what it says as of today, so if we need, whether the patient is on bevacizumab and BRCA2 positive, so that we all know how to practice. So if bevacizumab not received, BRCA mutated, then we have category 1 indication for OLA and NIRA. Probably RUCA will also be joining this group soon. So PARP inhibitor rechallenge, this we will not discuss, we'll leave it this. And upcoming studies, definitely PARP inhibitors in combination with various immune IU checkpoint inhibitors is on the horizon. And in the coming days, we may get to see the results even better way. So take home thoughts, the use of PARP inhibitors with and without bevacizumab in maintenance setting has been transformative. Definitely patients who have BRCA associated and HRD is there, they tend to do better with the PARP inhibitors. And in HRP tumors who have responded well to platinum, there may be reduction in hazard or progression or death is meaningful in these patients. So this, I'll stop here. And
Thank you, sir. Thank you so much. With lot of data coming, I think it will be more of confusing which PARP inhibitor to use in the first line setting.
Correct. Yes.
And maybe, sir, whether addition of this bevacizumab to the olaparib, this financial toxicity will be balanced by single agent olaparib
yes.
or rucaparib. That's one thing.
Yes, it is very valid thing because we all want minimum toxicity and maximum life. And maybe once the IO and PARP inhibitor results are available, we will be in a better position to probably say that Bev days with combination doesn't work. But as of now, looking at solo one, single agents may be better.
So in that case, means if we get the results of this rucaparib and nivolumab,
Athena mono. Yes,
this combo trial.
Yes,
so
combo.
We will not be sure what will the driver, whether will be the MSI or whether it will be the mutation that is driving that cancer.
Very true.
So means lot of data are coming, difficult to compare one with the other, but more of like it's like a confusion with us in starting with therapy.
Yes, at this point of time, as the data evolves, we'll be more wiser in coming days probably.
Thank you, sir. Thank you so much for your kind time. And the thing is, I know you are one most busy schedule and how you spare time. Thank you so much, sir.
Thank you, Dr. Jagdeep. Thank you, organizers. Bye.
So next session will be by Dr. Satyankar. So which will be taking next to one of the sportive treatments in the oncology, and it's one of the backbones. And we all aware of the NEPA, this combination of netopatent plus polanosetron. So over to Dr. Satyankar. He is a medical oncologist at EOI Jammu. So over to you.
Thanks, Dr. Jagdeep. So I'll be sharing my slides. Are they visible?
Yes, they are visible. So Dr. Satyankar, just one request that means we just, can you stick to maximum 12 to 15 minutes maximum?
Yeah, I'll try my level best. So basically, I'm be discussing about NEPA, Indian experience with NEPA. In the first few slides, I'll be discussing about the drug and later on the supporting studies. So what are the patient's perceptions of the most
sorry for the interruption. You need to make it a full screen.
Full screen, yeah. Okay. No.
सर एनेबल एडिटिंग को क्लिक करिएगा और स्लाइड शो मोड पे चले, स्लाइड शो पे जाइएगा सर।
जस्ट क्लिक हो रहा है, स्लाइड शो ये
तो स्क्रीन शेयर स्टॉप हो गया आपका।
I think it's okay now.
Yes, sir. Yeah, fine.
So what are the patient's perceptions of the most feared side effects of the chemotherapy? We all know, apart from general health, nausea, vomiting remains still a very dreadful side effect for the patients, and at times patients, compare severe delayed nausea as worst as having death. So it's very important for all the oncologists to take care of this particular side effect. So the probability of having uncontrolled nausea vomiting increases likelihood by every subsequent cycle. So if the patient experiences severe delayed acute and delayed CINV in the first cycle, then the probability of having the same in the second cycle is increased by 6.5 times and about 14 times in the third cycle. So it's very important that we prevent at the right right at the start of the chemotherapy, and it has some serious side effects and consequences like dehydration, electrolyte imbalance, muscular effects, mental consequences, malnutrition. At times esophageal tears have been reported. Severe impairment of the health related quality of life has been reported. Patients do go on to discontinue anti-cancer therapy quite often. There is increase in morbidity and mortality. There are delays in the discharges from the hospital, and of course increases the costs to the healthcare system. So these side effects can interfere with the treatment compliance. So coming to neurotransmitters, of all the well-known neurotransmitters, the two most important for the emetic reflex are serotonin and substance P. Serotonin predominantly acts in the gut and substance P in the CNS. So of all the various combinations that can be given to a patient who's receiving a highly hematogenic parenteral anti-cancer chemotherapy or moderately hematogenic chemotherapy, the preferred one is the treatment option A, which means we should give rather these 4 drugs: olanzapine, neurokinin 1 receptor antagonist, which can be either aprepitant, fosaprepitant, oral combination of netopitant palanosetron, or even now IV formulation of Akynzeo is also available. The third important drug is 5-HT3 receptor antagonist. Either of the citrons can be used, and most important, dexamethasone. So and out of that, olanzapine, dexamethasone has to be continued on day 2, 3, and 4 as well. And if aprepitant has been given, then on day 2 and 3, oral aprepitant can be given. Now, what is NEPA? NEPA, as per the MASCC guidelines and the ESMO guidelines, this combination has been, approved for the prevention of acute nausea and vomiting following AC and non-AC chemotherapy of high emetic risk. So, level of confidence is high, level of consensus is high, level of evidence, ESMO level of evidence is 1, and grade of recommendation is also A. Now, what is the pharmacological rationale for combining NETU and PALO? Because they act on complementary sites. So netopitrant is the next generation NK1 receptor antagonist. It is highly selective for the NK1 type 1 receptors with competitive binding and blocking of human substance P receptors. It has a high occupancy, more than 90% of the receptors of the substance P, which they are located at the area prosthema. And it's very long lasting, more than 96 hours. So single dose can be quite effective, in fact, for more than around 5 days. And similar is the pharmacological rationale of palanositron, because it also has a very high binding affinity and a longer half-life as compared to the predecessor 5-HT3 receptor antagonist. It is highly selective for the 5-HT3 receptors, and it exhibits a distinctly different receptor binding. It has allosteric binding, and it has a positive cooperative activity also. And it also results in long-lasting inhibition of the 5-HT3 receptor function. So whenever we give highly or a moderately emetogenic chemotherapy, it acts in the peripheral pathways, and there is also a central pathway. The peripheral pathway predominantly results in acute phase of the CINV, which is primarily in the gut. Serotonin is released, which can be blocked by 5-HT3 receptor antagonist. Whereas in the delayed phase of the CINV from day 2 to day 5, it is because of the release of substance P in the brain, and this can be blocked effectively by NK1 receptor combinations. So the similar and the complementary pharmacokinetic profiles of NET2 and PALO combine the synergetic effects of receptor antagonism, so supports the rationale. So this single tablet of NEPA has the potential to improve anti-emetic guidelines adherence. It has the potential to reduce the number of doses of anti-emetic in CINV prophylaxis. It has the potential to reduce mistakes in anti-emetic prophylaxis administration, and there is a potential of flexibility in the timing of anti-emetic prophylaxis dosing. So what is the Indian experience, the real life experience? So there have been 4 major studies published at various platforms, and this was Vaswani et al. In fact, they have been the pioneers. In fact, they have been doing most of the research work on NEPA Akensio. So the effectiveness of NEPA in the prevention of chemotherapy-induced nausea, vomiting among chemo-naive patients in an Indian setting. So what was the treatment? The treatment was given prophylactically before the first cycle of chemotherapy, and treatment with DEXA was given as per the standard practice, that is 12 milligram IV or oral per day. And both the patients of highly and moderately emetogenic chemotherapy regimens were included. Now, what were the parameters that were assessed? So we were the investigators assessed for complete response. Now, complete response basically studied only vomiting. They did not study nausea. So complete response was either acute or delayed. Acute was no vomiting and no need for rescue medication within 24 hours of chemotherapy, and delayed was from after 24 hours till about 5 days. So combining acute and delayed became the overall complete response. Now coming to nausea, it was when they studied nausea, it could be either overall complete protection, which meant no significant nausea, which means less than 2.5 on a VAS scale. So VAS scale is visual analog scale. The investigators gave away charts to the patient, and they were told to mark the this nausea rating from 0 to 10. So if it was less than 2.5, which means no significant nausea, and of course no vomiting and no need for any rescue medication, they were labeled as having overall complete protection. And complete absence of nausea, which means a VAS score of 0, was called no nausea. So these were the 5 parameters that were to be assessed by the investigators. So patient characteristics were like median age was 53 years, male to female ratio was 0.85 to 1, and highly emetogenic regimens were 260 patients were labeled in that, and the rest were in the moderately emetogenic, and mainly the highly emetogenic regimens we all know, cisplatin and AC based chemotherapy, and moderately are the FOLFOX and the 4-FIDI regimens. So what are the results? First of all, the complete response. The complete response, all the enrolled patients, the complete response in the acute phase, in the delayed phase, and in the overall phase was 93%, 85%, and same. And coming to complete protection means on a visual scale, this VAS score of less than 2.5, which means no significant nausea, and of course no vomiting and no need for any rescue medication. So complete protection was again in the high 80s, 88%, 81%, and 84%, 80% in the acute, delayed, and the overall phase. But no nausea, we see particularly no nausea, the incidence of no nausea in the overall phase was around 75% in the enrolled patients, with 76% in the high emetogenic and 79% in the moderately emetogenic chemotherapy regimens. The key finding of the study was that regimen-wise comparison also showed no difference in the overall response in the acute phase, the CR in the delayed phase, or in the overall CR. And gender-wise response also showed no difference in the CR response and among the male and the female subsets. The other study was also by the Vaswani et al., and it was they studied effectiveness of a novel fixed dose combination of NET2 and PALO in the prevention of chemotherapy-induced nausea, vomiting. It was again a real life study, and this was also a single study. It was again a retrospective, but the sample size was a little more. Inclusion was the same. Exclusion, of course, the low hematogenic chemotherapy regimens were excluded, but their primary outcome was to see the overall CR. They did not evaluate no nausea or complete protection. Baseline characteristics are largely the same. Another important thing about this particular trial was that they included not just the patients who were given chemotherapy in the first cycle, but of course, patients who were enrolled subsequently later. That means in the second, third, fourth, and beyond chemotherapy. And there a slight variation among the patients enrolled into the highly hematogenic, which was 54%, and moderately hematogenic regimens, which was around 45%. So overall phase complete response in this study was slightly higher, probably because moderately hematogenic population was around 45%, unlike the first trial. So overall phase complete response was very high, almost 94%, and CR in the acute and delayed phase was again 98% and 93%. And among when we studied the responses in the as per the chemotherapy cycles, there was again in the high 90s. So to conclude, NEPA is highly effective in preventing CINV in patients receiving highly and moderately hematogenic regimens with CR rates of 93% in first real life evidence. Response was maintained irrespective of the regimen. Response was consistent across the number of chemotherapy cycles. Single oral dose NEPA targeting dual pathways showed effective control of nausea vomiting in patients in both the regimens and has a good control in acute, delayed, and overall phase also. So this paper was published just last month in September 22, and they particularly, this was a post hoc analysis, and they wanted to see what about the patient having, only the highly hematogenic chemotherapy regimens who are having high risk, and what is the results in this subset of patients. Now, this particular study was an open label, single arm, and this was a prospective study. It was, studied across 6 centers. And this had, of course, the ethical approval, and this is the registration details. Now, they wanted to study complete response and treatment emergent adverse events. And there were, of course, the secondary endpoints also. Complete protection I have described, but there is something new called as a complete control. Complete control means no nausea as well as the overall complete response, which means no nausea, no vomiting, and no need for any rescue medication. So this was something new in this trial. So again, the same thing, the highly, but this study only enrolled the highly hematogenic regimens, which were AC or Paclicarbo. Paclicarbo means the carbo has AUC more than 4. So these were the results. If you see the p-values, all are significant, and the results are quite similar to the studies shown early. And this last study, this was again done by Vasrani et al. And what they did was they specifically studied the high risk group, the female gender, young age, first chemotherapy cycle, and low alcohol intake have always been associated with increased risk of nausea and vomiting from chemotherapy. Now, this post hoc subgroup analysis was done to see if netopitant and palinocytron combination in this particular high risk group was effective or not. So this was a retrospective study, and just about 51 patients were enrolled in this study. And what they found was complete response, which means no vomiting and no need for rescue medication, was more than 80%, 85% in this subset as well. So complete protection, which means less than 2.5% on VAS score, was around still more than 75%. And if you talk of complete control, which means no emetic episodes, no rescue therapy, and no nausea, was obviously just around 70%. So single dose NEPA targets dual pathways, has showed effective control in nausea vomiting in high-risk patients also. Thank you so much.
Thank you, Dr. Satyankar. So it's a long time back. We have not gone through any of the supportive therapies, and it is one of the backbones when we are treating our patient with the chemotherapy. And NEPA has shown the promising results, and shortly we will be having the IV formulation of the NEPA also. So right. Thanks for your kind time. Thank you so much.
Thank you so much. Thank you so much.
Next session is by Dr. Gurvinder Singh. He is a consultant medical oncologist at CCA Ludhiana. So he will be giving lecture on another one of the most important aspects of the chemotherapy treatment. It's of the PIC line. So picking up the right vascular access devices to the chemotherapy patients. Over to you, Gurvinder.
Thank you, Dr. Jagdeep. for this invite. So I will be talking about the venous access device in cancer patient. What are the guidelines and Indian experience from Rajiv Gandhi Cancer Institute? So why there is a need of any venous access device in a cancer patient? Because you have to deliver drugs, fluids, blood products, and if any nutritional therapy. And these patients, they have frequent need for blood testing, for monitoring, and before every chemotherapy to check for the eligibility for chemotherapy. Next slide, please. So what are these central venous access device? They are basically of external catheters or implantable ports. External catheters, they are basically divided further into non-cuffed and cuffed. Cuffed tunneled are catheter like Hickman, and non-cuffed are peripherally inserted catheter lines, central lines, PICC lines. Next slide, please. So devices, they are categorized by insertion site, peripherally inserted or centrally inserted. Peripherally inserted are PICC lines or caofix. They are inserted, placed into small veins in the periphery, and they go then to the superior vena cava. Centrally inserted, they are directly inserted into the larger veins, which are Hickman or subcutaneous porta cath. Next slide, please. So how to choose or pick the right venous access device? It is the primary clinician duty to select the appropriate catheter type that accommodate the patient's need, and along with that, we have to see what is the treatment duration of the patient, anticipated duration of treatment. Next slide. So this is basically algorithm. If a patient is needing less than 4 weeks of therapy, then peripherally inserted catheters or midline these catheters, they are sufficient. But if a patient is requiring long duration therapy more than 4 weeks, then either we have to consider PICC lines or port or Hickman. In Hickman, basically for patients who are having need of more this prolonged infusion, and they require this increased flow rates like in patient with the transplant candidates. So in them, we have to use these venous access device. Next slide, please. So intended lifespan, lifespan of the device, it also depend. If a patient is that we have discussed in the previous slide, if we need a patient who require a therapy for more than equal to 4 weeks, then we definitely need these venous access device, either PICC lines or tunnel catheters or implanted ports. Next slide, please. Oh, this is basically a picture of a peripherally inserted central line, PICC line. Next slide, please. So what are the basically use of this PICC lines? They require therapies which require central venous catheters, irrespective of duration of therapy. Then more than 6 weeks, more than 6 days, or less than 1 year. Multiple agent IV therapies can be administered, and any fluid which have a pH less than 5 or more than 9, or osmolality more than 600 per milliosmol per liter, they can be infused to the PICC lines. Next slide, please. Advantages of a PICC line: they can be inserted by a trained nurse, no need of any special training. And PICC line nurse team, they can take care of insertion and then maintenance. It doesn't hamper with the mobility of the hand. Easy, almost 100% success with the USG guidance. Low infection rate are around 1.5% to 2% hardly, and they can be used for a longer duration, even up to 1 year, and they can be easily removed at the time of complication or infection. Next slide, please. So disadvantage of PICC line: they are visible outside, hanging. There is a risk of pulling out. They need a regular dressing and flushing. That is very important. And can't swim if definitely if there is a PICC line in situ. Difficult for fast and high volume infusions. And there is sometimes a difficulty with sampling also, as the lumen is left. Next slide, please. So PICC line, if there is no PICC line, then definitely there is a risk of extravasation with the chemo drugs. Next slide, please. Which sometimes can lead to dreadful skin complications. So if we talk about extravasation, what are the signs and symptoms of extravasation? There is basically always a complaint of pain or burning at the site, swelling, proximal or distal to the IV site, puffiness of the dependent part of the limb, skin tightness, blanching, coolness of the skin, or infusion slow rate. There is a difficulty in giving that drug. Next slide, please. So these most chemotherapy drugs, they are either vesicants or irritants. Vesicants, there is a complete list. Anthracyclines, basically they're vesicants, which are alkaloids and alkylating agents. Next slide, please. Irritants, these are the chemotherapy drugs which are irritants, like DNA interglating antibiotics, epiphotophyllotoxins, antimetabolites, alkylating agents, and then taxanes. Next slide, please. So managing extravasation, important and first step is always stop the infusion, withdraw the drug, but don't withdraw the IV catheter. We have to keep it in situ and aspirate whatever we can. Then elevate the limb to reduce the edema. Applying heat for vincristine and vinblastine, that is a Vinca alkaloids, and cold packs for anthracyclines. And subsequent management will depend on the drug involved and degree of damage. Next slide, please. So management of complications, treatment, if there is any infection, then we have to definitely use antibiotics or medicines to dissolve blood clots if there are. And if there is abscess, we have to drain it. And if either giving antibiotics for 48 to 72 hours, there is no improvement on the local infection, then we have to definitely remove that device. And if there is a culture positive infection by Pseudomonas or Candida, we have to remove that device. We cannot use it. And reinfection by an organism after appropriate antibiotic treatment is also indication for removal of device. Next slide, please. So prevention and protocols, if there is usually a thrombosis, how can we prevent? For thrombosis, proper flushing and proper frequency. For PICC lines, it is twice a week. Hickman is always daily, and port monthly. And low dose blood thinners may also help. Next slide, please. So it is basically just an experience from Rajiv Gandhi Cancer Institute. Nationwide efforts are trying to reduce preventable deaths in India in hospitals. So most of the things, this central venous access device is the bloodstream infection, which is a deadly complication. But with the due care, the rates are around 1.5 to 2%. Next slide, please. So how can we prevent this central bloodstream infection? There's a term called bundle, which consists of basically 5 interventions to reduce the bloodstream infections associated with venous access device. So these 5 steps basically are hand hygiene, use of maximum barrier precautions whenever we are using that device or inserting it, chlorhexidine for asepsis of skin, and optimal insertion site, and daily review of the device if necessary. Next slide, please. So it was the data from Rajiv Gandhi Interactive Data 2019 to 20. Total, they have inserted around 1,200 lines, and DVT cases were around 0.83%. As infection, central bloodstream infection, you can see that it was around 1.57%. In talking about the nutshell, if we need a device, central venous SD with higher flow, patients of BMT who are undergoing transplant, Hickman is the best thing. And for other things, if we don't need multiple lumens and don't need this much high rate of infusion rates, then we can think of either of a port subcutaneous or a PICC line. The only thing is it is up to patient If patients are suitable for, there is no worry about cosmesis, then PICC line is also good. But if a patient is worrying about the cosmesis thing, then port is the best thing that we can get up. So thank you.
Thank you, Gurvinder. So again, what I said to Satyankar, listening after long about this, one of the vascular access devices, which is our main backbone in the chemotherapy patients. So thanks for this precise lecture. So thanks all the people listening to this conference. Thank all the participants and the attendees. And thanks again to the SOMEX for organizing this event and making the things comfortable at my end. So over to you, Mr. Tar, or Ekta or Pooja can take the.
Yeah, thank you, sir. Thank you, everyone, for this 2-day academic feast. Thank you for joining. And we had a grand, like, celebrations type of the talks were so good. The discussions were so awesome. And thank you, everyone, for joining. Good night. Good night.
Thank you so much.